Good morning and welcome. I'd ask you to stand for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. Good morning and welcome. First bill of the day is Senate Bill 606. An act relative to insurance coverage for biomarker testing. I'm going to open the hearing and ask Senator Birdsell to introduce her bill.
Thank you, Mr. Chair. For the record, my name is Regina Birdsell, State Senator for District 19, which encompasses the towns of Derry, Hampstead, and Windham. And I'm here as the prime sponsor of Senate Bill 606, as you said, the biomarker testing. There's an amendment. I don't know if you've all gotten it, but I did give copies to Sophie. What we've done, just as a summary, what we've done is we've taken it completely out. We've amended the whole bill to only have biomarker testing for Medicaid recipients only. And I'll explain why, but what I want to do is talk a little bit about biomarker. As you've seen some of the pamphlets that have come out, biomarker is the analysis of patients' tissue, blood, or other specimen for the testing for the presence of any biomarkers. And biomarker is an important step for accessing precision medicine, including targeted therapies that can lead to improved survivorship and better quality of life, especially for cancer patients, but it's also being used in many other areas. And what it does is it actually takes a specimen of the tissue and it looks at it, and they are able to, by looking at the biomarkers, they are able to see which medicines would work on these particular specimens. And it also takes into effect, if you are on medications, if you're on certain medications, how will that treatment that they're giving you affect? So if you're on a medication that maybe one treatment wouldn't work, they can test that out and then change the medication. So while most current applications of biomarker testing are in oncology and autoimmune diseases, there's research underway that's going to benefit patients with other conditions, including heart disease, Alzheimer's disease, and many other neurological conditions. And bless you. This legislation has been put through in the past few years. However, it usually mandates it to commercial carriers. The biggest pushback on this legislation has been the cost, which supposedly it passes on to the ratepayers. This time, the legislation is aimed at biomarker testing for Medicaid recipients with input, and this is approved from DHHS. This would allow us to collect data to review the impact and potential savings on early treatment of patients. So this will give us a data line because, again, what the insurance companies have said is it's going to cost a lot of money. Well, how many recipients are going to be being able to use this? And we'll be able to pull that data from the Medicaid recipients, and then we'll have further down the line, if we see that there is a cost savings, especially with early treatment, we have more incentive to go forward and basically mandate it.
Very good. Thank you. Are there any questions for the senator? Thank you very much.
Yep. Thank you.
Dr. Ballard and Henry Littman from DHHS.
Good morning, Chairman, and committee members. My name is Jonathan Ballard. I work as the Chief Medical Officer at the New Hampshire Department of Health and Human Services.
For the record, Henry Lippman, the state's Medicaid Director.
We're here to provide information regarding Senate Bill 606 and the subsequent amendment. Biomarkers are an important part of modern therapy and treatment for individuals. And in fact, we do cover some biomarkers today in the New Hampshire Medicaid program. There are a significant number of biomarkers, though, that we do not currently cover. The standard for coverage in the Medicaid program is determined by the Center for Medicare and Medicaid Services use of medical necessity, something being medically necessary. And so there are lots of different approaches for that. There are different statements, different clauses within this bill that comes to determine medical necessity. But the Medicaid program essentially refers back to the definition of medical necessity that is published in the Federal Registrar that became effective in 2021. It's published in the Federal Registrar, and it talks about services that are reasonable and necessary, that are safe and effective, that are furnished in an appropriate setting, that are ordered and furnished by a qualified personnel, and meets and does not exceeds the patient's medical need. And the benefit has to exceed or at least be equal to a medically appropriate alternative. So those are the definitions we follow. If we do not cover something that's medically necessary, or if we cover something that's beyond medical necessity based on CMS, then the state Medicaid program is not eligible to recover the federal match. In the federal match is different for different populations. For some individuals, it's at 50%. In the expanded Medicaid population, known as Granted Advantage, it's at 90%. So that is a significant funding source to be able to cover services. With this amendment, it does a few things that are very supportive in helping us as a Medicaid program to ensure that the language is compliant with us to maintain medical necessity. We refer to the Medicaid program as determining medical necessity because we apply the federal CMS rule for medical necessity. The original underlying bill looks at the treating provider or the ordering provider as determining medical necessity, which may not be in line with the federal statute regulations. So it does tailor it to making sure that that component is met. It does a few other things. It makes the bill effective starting at the next budget period. So that in that case, for this immediate need, there would not be an additional budget request until the end of the biennium. We have worked with our budget actuary. I have actually discussed biomarkers extensively with my counterparts, other Medicaid medical directors across the country. There are several states that are now covering biomarkers. One particular state that has taken on this more proactively than others and looked at each individual biomarker and has applied that medical necessity standard is the state of Florida. So they have a publicly listed list of biomarkers. There are thousands of them out there, but the Florida list is more in the hundreds of biomarkers. So that's a source that you may wish to look at.
Thank you, Dr. Ballard. I think, I don't know if I've seen, want to make sure looking at the amendment. I know there was one, yes, okay, yes, line 27 on the page 2 was added in there that, obviously we need some funding to deal with it. Now, what does the funding look like? Our actuaries, Milliman, actually, the team that works in New Hampshire also works in Florida in part. So we have some good connections there. So we have a low estimate and a high estimate. And this is the incremental cost. And we just got this information yesterday, so we're going to put it into a fiscal note so you have that information. But on the low end, the estimate would be Total expenditures would go up by $520,803, of which state funding would be $166,657, based on a blended percentage of the 90s, the 50s, and the 65% federal match. So the state funding at the low end is just under $167,000. On the high end, the total expenditures would be estimated to be $1,874,892. Call it just under 1.9 million. The estimated state share would be just under 600,000, 599,965. And again, we'll have a fiscal note. We'll incorporate this, and this is the incremental amount over what we're already covering.
Thank you. Are there any questions? Senator Abard.
Thank you. Getting back to the definitions, I was kind of vague on understanding who determines whether it's above or below, standards. Your definition kind of left me in the clouds.
It's based on the standards of medicine, of whether it makes a difference typically for the patient or not in their treatment. It's how I interpret that standard. So ultimately, the CMS refers back to the Medicaid program. So that would be the Medicaid managed care organizations, their medical directors, myself, interpreting the federal statute against the medical need that's put forward through an authorization request for the service.
If I may have one follow-up. Thank you. And so, we're looking at the fiscal potential low and the high end of it. And I'm thinking that, if it's a good practice to get those biomarkers, are we looking at a cost benefit that could actually save us money?
That's indeterminate at this point from our perspective. I know that there are some other states that are looking at that actively, and there may be some potential savings. I think that at least for upfront, though, there would be cost, initially, obviously. I don't have the evidence yet as far as how long out that you may see some potential savings in choosing one therapy over another.
I think like some other things, when we were looking at like adult dental, it takes some time, like matching the periods of expenditure and when the benefit comes. And some of it is what I would call externalities, that it may not benefit the Medicaid program, but it may benefit citizens who can work and have a healthier life and be able to be a greater contributor to society. So in terms of being able to target it, and I think the state of Florida has, their legislature is monitoring the implementation of it. I think it's kind of early on to make that judgment, but I guess the good news in terms of relative terms of total Medicaid spending, it's a relatively small number.
I think the other important fact, though, is that the average person on Granted Advantage, who would be the population I think would most benefit from this, is on Medicaid for less than 1 year. So they're on Medicaid. We're still going to have the expense on Medicaid, but the cost savings won't come back to Medicaid.
Final one, I promise to be quick. And so would this be just good medical practice?
Yes.
Thank you.
And just to follow up on Senator Abard's questioning, and I know you don't have the data, but theoretically, we could spend, that fiscal note number is the gross. But theoretically speaking, we could run a biomarker test, determine the most appropriate therapy, deliver that therapy, get a cure, and save us from spending a whole bunch of other stuff wondering if this is the best way to go.
Yes, and this is the term you'll hear thrown around a lot called precision medicine.
If I could just add something, when I was speaking to externality, what we're trying to do with policy in general is have people leave Medicaid to be able to get other insurance. So the benefit may accrue to someone other than the Medicaid program in terms of what the long-term costs are, because we've done something in Medicaid.
Great, thank you. Are there any other questions from the committee? Senator Long.
Thank you, Mr. Chairman. Thank you for your testimony. How many biomarkers do we cover currently?
That's a great question, Senator. Thank you for that question. It depends on what you determine as a biomarker. As the definition of biomarker is currently in the bill before you, it's a very expansive definition, and it covers any test that contains a piece of tissue, as Senator Birdsell says, that determines the course of action. So I don't have an exact number, but with that definition, it's in the hundreds of types of tests that we cover. There would be a few more hundred, though, that I think we're looking at that are the genetic types of tests, the tests that look at whole genome and such that really can determine that one test or medicine is or treatment is the best for you based on your individual situation. And so that's the test that we would be adding that would be in the hundreds of additional tests.
Great, and a follow-up on me. Have you determined in the past that a biomarker should be done? And the Fed said that it's not covered in our explanation.
So other states have, but we have not. I have seen direct communications from my fellow medical directors in other states that they've had requests for different biomarker tests that they felt that were not medically necessary, that would not change the course of treatment, that there was not evidence yet in that particular situation that would warrant or allow for the federal match to be paid for.
Right.
So they go both ways.
Right, thank you.
Are there any further questions? Thank you very much. Mike Rollo.
Thank you, Mr. Chairman. As members of the committee, for the record, my name is Mike Rollo. I'm the Director of Government Relations for the American Cancer Society here in New Hampshire. And we are appearing in support of Senate Bill 606 as submitted and potentially as amended. We haven't actually seen the final copy of an amendment, so I'm going to try to speak in broader terms because I'm waiting to see the final copy of it, but that you all have. But we are more than willing and looking forward to working with the committee and the department to move this bill forward for sure. Senator Birdsell already covered half of my testimony, talking about what biomarkers are, and Dr. Ballard was kind enough to cover some more of it, so I'm not going to bore you with all of that. But I think it's a couple points I'd like to make. And we've talked about this now for a few years now. This committee was kind enough to pass the bill unanimously last session. We're hoping we can move forward again this year in the same manner. But I think it's clear just to state that not all communities are benefiting from access to biomarker testing across the board. We see this across the country. It may depend on where you live, what your socioeconomic status is, whether you're getting your treatment at an academic setting like at Dartmouth or a non-academic setting. So there are barriers, and Medicaid recipients are also part of the class, if you will, of folks that may have barriers in receiving that across the country, not necessarily just in New Hampshire. But so that's why I think it's important, even if we're not moving forward with both commercial and state-sponsored health insurance, that we just move forward at least with the Medicaid portion, because these folks also need to have greater access to this testing. But to be clear, biomarker testing is not indicated or appropriate for all cancer patients. And we're not advocating for universal biomarker testing, as has been said in the past by some folks. Rather, this legislation is tied to rigorous sources of medical and scientific evidence that guide who should receive the testing. In addition, you'll see demonstrated stories from last year and from this year. On the next page of my packet, you'll see a letter from Ms. Nancy Carney, who testified before you last year. She had a conflict this morning and couldn't be here. Now, to be fair, Nancy's case deals with commercial insurance, so it's not apples to apples at the moment if this amendment moves forward. But I think that her story speaks to the necessity of access to biomarker testing and what happens to a patient after they've had access and received the most appropriate treatment, then they get a surprise bill in the mail. We don't want to see anyone else having that happen to them. But it also shows that in Ms. Carney's case, she was able to avoid a very invasive and expensive surgery because of a biomarker test, which would also carry over for folks on the Medicaid program. The next page you'll see is information on what biomarker testing is. The senator also covered quite a bit of that. Also, the next is biomarker testing, advancing precision medicine. But the last part of our packet, I think, is probably what will interest you all a lot this morning in this biotesting and cost savings. There have been, to date, 26 states that have passed this policy in one iteration or another. Some states have gone the route of that you're looking at the moment of only doing Medicaid. Some have done both. And if you've seen, as it's been said in this room many times before, if you've seen one Medicaid program, you've seen one Medicaid program. It's kind of similar to this legislation. States have, for the most part, followed the model legislation from our coalition, but there are states that have changed it, much like what you're looking at doing today. But in the biomarker testing cost savings handout that you have here, there are actuarial analysis from Milliman, which I will provide. I did not print out the 100 plus pages for you today, but I will email them to you after the hearing. And I think you had them last year also. But it shows the costs to the Medicaid program on average for testing and commercial and potential savings for each. So I think that's important to look at and to note, because I think your questions have been leading, they're hypothetical, but they've been leading in the right direction, that passing this policy has the potential to save the system resources. And that's not necessarily our guiding light at the Cancer Society. We want to make sure that folks have access to the most appropriate treatment possible and have better outcomes. But if we can also save the system resources at the same time and shore up the system, I think that's positive for everybody. Now, again, I have not seen the final version of the amendment. I know one version I saw did not have definitions for medical necessity. Just listen to Dr. Ballard's testimony. I would need to see the final copy of the amendment and have our policy folks look at it. But I will tell you that in the states that have passed this, the majority of them have defined that included medical necessity. I don't know, like I said, I don't know if your draft amendment, Senator, has it in or not, but we would be concerned if that wasn't listed. But again, we're more than willing to work with the committee and the department because we want to see this issue advance. We also are concerned about, I need to do my due diligence. Senator Rochford and I had a conversation yesterday, but I have to say it again. We are concerned that we would be delaying this implementation into the next budget. Mike Rollo is also a realist and lives in the real world, but I have to do my due diligence. We are not in favor of that. We'd like to see it enacted sooner rather than later. And with that, I'm more than happy to take questions. But again, I think I just want to emphasize that, again, we haven't seen the final version of the amendment, but we're more than willing to work with the department and with you all to make sure that this legislation advances. I thank you, Senators.
Great, thank you. Are there any questions? Thank you very much. Oh, we got one question here.
Mike, I have a copy of the amendment if you want it. I have two.
Thank you very much for that, Senator. I will forward this. I might just take some screenshots and forward it on now to our policy folks. But I'm just happy that, and I know we're very pleased that this is being worked on. And again, we're more than willing to work on some sort of compromise to make sure it moves forward. So
Great,
thank you very much. Appreciate your time, Senators. Oh, and I wanted to say one more thing. I'm sorry. We wanted to thank Senator Birdsell and Senator Innes for their past support and leadership on this, in the full committee, honestly. I mean, you all did a lot of work on this last year. I know we're all sad that it didn't get over the finish line, but we wanted to thank you for your past support and work. So, thank you.
Thank you very much. Michelle Heaton.
Good Good morning, Michelle Heaton. I'm the Director of Life and Health at the New Hampshire Insurance Department. We signed in to speak because the bill was, as written, going to impact insurance. It sounds like with this amendment, the intent is to not impact insurance and only Medicaid. I did take a quick look at the amendment, and the amendment does still include reference to 420J. If the intent is to limit it to Medicaid only, then I would just remove all the references to 420J. I think it's confusing and unnecessary. But since insurance is out of it, I don't have anything further, but I'm happy to answer questions.
Are there any questions for Michelle? Thank you very much. I've got 3 for the Alzheimer Association. Do you guys all want to come up together? All right, so we've got Jenny Horgan, John Ziemba, and Kathy Harper.
Good morning, Mr. Chairman, members of the committee. For the record, my name is Jenny Horgan, and I am the Senior Public Policy Manager for the Alzheimer's Association here in New Hampshire, and I'm joined by
Kathy Harvard from Hanover.
And I'm John Zimba from Epping.
So again, we want to echo the really great comments from our friend over at the American Cancer Society, Mike. His testimony, we certainly want to echo that, as well as our gratitude to Senator Birdsell and members of the committee to continue to work on this with us. We are also aware of the amendment and some of that language, and we really do look forward to the opportunity to continue to work with the committee and the department to ensure appropriate coverage and hopefully move this forward. So I know I saw you all last week, so just very briefly on the facts and figures that we want to make sure that we're covering here. There's more than 26,500 individuals living in the state of New Hampshire with Alzheimer's or dementia. And that number is likely higher. People often face significant barriers to get a diagnosis in the state and get that timely, accurate one, which we believe that this bill would assist in that. As our population continues to age, the impact of this disease will only continue to grow on families, caregivers, our long-term care systems, our healthcare providers, and the state budget, importantly. So Alzheimer's disease is often diagnosed only after cognitive decline occurs, at which point severe brain damage has already taken place. Advances in science now with biomarker testing have shown really promising ways to improve early detection, diagnosis, and management of the disease. This is especially critical given that the FDA has recently, in the past couple of years, approved treatments for Alzheimer's disease that delay the progression of the disease at the earliest stages. So that early diagnosis is critical to getting the treatment when it is most effective. So that, again, diagnosis earlier affects allowing for earlier intervention, better care of individuals, better care planning, and improved quality of life for grant staters. It also benefits families by providing clarity and access to support services. And if people are able to appropriately access treatment following a diagnosis, it benefits the state by reducing long-term care costs and overall strain on, again, our long-term care and our healthcare systems. Echoing, the cost savings, and, Senator Avard, thank you so much for, pointing out that the cost savings of an earlier diagnosis. An earlier diagnosis, according to national data, could save approximately $63,000 per person. That's $30,000 in Medicare savings, $20,000 in Medicaid savings, and an additional $13,000 in other cost reductions. So New Hampshire has already seen a huge significant financial strain from Alzheimer's with an estimated $363 million spent in Medicaid spending related to Alzheimer's and dementia in 2025 alone. And these costs are going to continue to rise as healthcare costs rise and prevalence of the disease increases. So we certainly support the expansion of biomarker testing to ensure that we're keeping pace with the scientific advances that are going on. This would expand it to medically necessary biomarker testing for Medicaid under Senator Birdsell's amendment. And these tests, again, can be used to diagnose, treat, manage, and be most effective in these important disease-modifying treatments as they come out. So without this legislation, individuals may wait up to 2 years for a dementia diagnosis, delaying those treatments and increasing overall costs and reducing quality of life. So for these reasons, we ask for your support of Senate Bill 606. You'll hear from our two amazing advocates here talking about the personal impact on their own lives that an earlier diagnosis may have assisted with. So again, we're happy to work with Senator Birdsell, with the committee and the department, and our friends over at the American Cancer Society to work on this language, and I'm happy to answer any questions.
Any questions? No, thank you.
Go next.
Again, my name is John Zimba. My wife died 3 years ago. She had Alzheimer's. She was diagnosed 3 years prior to that. I remember it like it was yesterday. It was January 19th, 2020. It was our anniversary. She did not remember the date that day, and when she was reminded of the date, she did not remember the event. Clearly, the disease had advanced. Much of the following years I remember very well as I was her caregiver. But I want to focus for a couple of minutes on the years prior. My best recollection is this journey started about 4.5 years prior to that. She was about to turn 62 and wanted to take Social Security. I was against it. I wanted her to wait. But she didn't think she would be around for another 8 years. I can't give you a lot of specific like these other folks as far as cost goes and dates and things of that nature, because I never thought I would be here today. She said she felt off. Her memory seemed to be fine, but she was experiencing other issues like anxiety, sleeplessness, migraines, to name a few. In those years, she went to her primary care physician, another female PCP, her gynecologist, her rheumatologist, a psychiatrist, a geriatrician, and finally a neurologist, all in those 4.5 years. Throughout all of these visits and testing, the general feeling was that she needed a medicine adjustment, or it was the result of, or at least influenced by, menopause. I can't tell you for certain that biomarker testing would have changed the outcome for my wife, as that was nearly 10 years ago. But a lot has changed in the last 10 years. I will say this, it certainly would have changed the journey. If nothing else, it would have given us more time to prepare legally and financially, more quality time with family and friends, more time to enjoy the time left rather than spending it with doctors with the highs and lows. Thanks for your consideration.
Thank you for your testimony. Are there any questions? Thank you very much.
So good morning, Mr. Chairman and members and friends on the committee. Thank you very much. Again, I'm Kathy Harvard from Hanover, and I'm really very pleased to be back here again this year talking about my family's experience and why biomarker testing is so critical to Alzheimer's disease. My late husband, Andy Harvard, and our family experienced firsthand how important biomarker testing is for those who are living with Alzheimer's disease or another dementia. At 59, my husband was abruptly fired from a job he loved and was ostensibly very good at, and neither his employer, his healthcare provider, Andy, or I had any idea that the very small changes in his behavior were actually the result of the effects of early Alzheimer's disease. As is typical for many who were in this situation, his diagnosis was challenging to get and very slow in coming. 9 months after he'd lost his job, Andy was diagnosed with mild cognitive impairment, not with hard data from biomarkers, but from what was available at the time. It wasn't convincing. It took another 2 years later until biomarkers finally confirmed that he had younger onset Alzheimer's. By that time, it was too late. The job was gone, disability eligibility was gone, health benefits were gone, and we were on our own. And our story is not unique. Getting an early and accurate diagnosis is the first step in knowing for any disease to what to treat and how to manage it. But it is especially important with Alzheimer's disease. In the early stages, Alzheimer's is often an invisible disease. It's difficult to recognize, it's tough to identify for family members and, frankly, many healthcare providers. And biomarker testing makes the invisible visible. It opens the door to diagnosis, the possibility now of treatment, and the ability for a family to plan. There have been extraordinary and remarkable scientific and medical advances in very recent years, and we now have FDA-approved tools that can aid in the diagnosis of people with symptoms of Alzheimer's or dementia. And just in the last 12 months alone, there have been remarkable advances in blood-based biomarker testing. And these will increase access to earlier detection, they will save money, and they will provide less impact, they will reduce impact on our healthcare system. For someone with Alzheimer's, receiving an early diagnosis gives families the ability to plan the difficult road ahead, and importantly, it offers the possibility now of medical treatment to slow disease progression. That was not the case just a few years ago. It is now. Today, however, the wait for testing is still long, the cost is overwhelming for many, and the clock is already ticking for those who could benefit from treatments that are only available at the very earliest stages of the disease. The window will close if they are not diagnosed early enough. So as Jenny said, today there are more than 26,500 New Hampshire families who have a diagnosis and are struggling every day with dementia. And there's so many more that have not even been diagnosed. We don't even really know the total numbers. Access to early and accurate diagnosis of dementia through biomarking testing is the first step to better care and support and the possibility for treatment. Senate Bill 606 would help ensure that some of the financial barriers to biomarker testing are removed, and these critical diagnostic tools are accessible to those who need them. Thank you for your support. This is a good bill.
Thank you very much. Thank you for your testimony. Are there any questions from the committee? Thank you all for coming in today. It means a lot to hear from you. Appreciate it. That's the last sign up we have for 606. Is there anyone else that would like to speak on Senate Bill 606? With that, I'm going to close the hearing. Yes. I am ready. We are going to open the hearing on Senate Bill 480, limiting certain prior authorization requirements for physical therapy, occupational therapy, and similar rehabilitative services. I'm going to ask Senator Prentice to introduce her bill.
I always feel this need to tidy up the chairs and microphones. Good morning. For the record, my name is Sue Prentice. I'm the state senator from District 5 representing 15 communities. I'm here to introduce Senate Bill 480. And what this would do would be limiting the use of prior authorization by health insurance carriers for both physical therapy and occupational therapy. Under this bill, insurers may not require authorization for the first 12 visits of each new episode. And so a new episode is going to be defined here as treatment for a new condition or for a condition that has not been treated in the previous 60 days. This bill preserves the insurer's ability to deny claims after a review, and it also serves services that are determined not medically necessary. So it doesn't touch those. It ensures cost controls remain in place, and beyond the initial visits, the intent is to reduce administrative barriers, treatment delays, and unnecessary paperwork that can interfere with timely patient care and recovery. There is no appropriation to the state, appropriation needed from the state. And I'm sure, I imagine that the Department of Insurance has signed in to speak on costs as this does relate to the health plans. I have a few high points that I want to hit, but I do want to say, out of the gate that I recognize that the health plans, and I've been in this position before when talking, first of all, we know that anytime we come out and we start talking about mandates for health plans, that as we heard testimony last week is, something that can produce potentially downward pressure on the plans and increasing costs. So mandates are, as we open the door and start to talk about them, can almost be a stop in a conversation. But I do think we need to dig into this a little deeper and see where some of the potential savings may be, not just for our patients, but for those that provide care and ultimately the plans. I have spoken preliminarily with a representative from AHIP and another one of the plans, because I think that we're going to need to have a little coordination. There may be a middle ground here. I'm asking for 12 without prior authorization. There may be a place in the middle. Different plans have different numbers that they don't require prior authorization for, so coordinating that still needs to happen. But let's just say a couple things about this. So what this bill does is it limits the ability for prior authorization by saying up to 12 visits. And I'm willing to move on that depending on where we're at with the different health plans. But we have to pay attention that a new episode, would be different. This matters because prior authorization can delay care. And I'm just going to share from a really personal perspective that my experience has been pre-COVID. If you were looking for, you had access to care issue. Well, there weren't as many access to care issues, honestly. But, finding a physical therapist and occupational therapist that could assist you. And I was looking for one when I was first diagnosed with, basically my, hip dysplasia and needed a new hip. The first line of defense, which is the most cost effective, and I'll share some numbers with you, is physical therapy. I mean, ultimately knowing in that case that I was going to need to go to an OR, but better preparing me for it. When I tried to get a physical therapy appointment, the workforce issues are significant and they are so behind that it was 8 weeks before I could get an initial evaluation. And I thought that was, I felt terrible about it for those that provide the care and for other patients who are trying to get in, that need what I need, but are not always in the same position to understand or work in the different advocacy routes that are available to them. What this can do for people is if they are already receiving care, and let's say 6 visits is their limit, and they have to get pre-authorization, so they have to stop the care, get another authorization, then how long will it take from there to get them back into, an appointment and back they're already established with a certain physical therapist or occupational therapist, but how long will it take to get them back into that loop? And again, just think about, even though my experience is slightly different, that access to care issue, which I believe is based largely on workforce, put me in a position where I was many weeks behind. So I think that is a really important point to make in this. So when we look at say a doctor's appointment and going to see a surgeon, if that was our first line of defense for, we'll talk just about orthopedic issues here, which are primary targets around physical and occupational therapy, it runs anywhere from $300 for initial evaluation to $4,000, and surgery can be anywhere from $10,000 up to $100,000. And we can potentially so it's less expensive to look at the physical therapy route, which many times works and gets us into a position where surgery isn't even needed. So physical therapy, it's $110 to $891 for an initial evaluation, but running somewhere between $75 to $350 per sessions and treatment going forward. There's like a really big difference in the order of that. And there are times when physical therapy in itself is the way to solve the problem. It's not always the need to have physician or orthopedic and ultimately surgical intervention. So there is an opportunity here to save money for the provider, the health insurance providers, improve access for patients in a more timely way. It's going to reduce some of the bureaucracy around the paperwork that needs to be done. Ultimately, for our patients, we're looking at better outcomes and cost containment, especially if they're having to pay for some of this out of their own pocket. There's no direct cost to the state, but I am clear that there could be costs to the plans. And I am, I have worked with the plans before on other like bills and look forward to the continued conversation on how to find a middle ground that aligns with patient-centered care, reduces barriers, improves access for patients that are in need of both physical and occupational therapy. I appreciate the opportunity to introduce Senate Bill 480, and I'm happy to take any questions that you have.
Are there any questions for the senator? I just have to say there's 4 out of 5 of us are co-sponsors of this bill. But I think that since signing off on that, there have been some concerns raised, which you brought those up. So I am going to task you with you mentioned that you will do this, task you with working with some of those stakeholders to see if some of the concerns can be alleviated with this. So.
Yeah, thank you, Chair Rochford. And it's a pleasure to work with the providers of the health and those that are here representing the health insurance plans as well as the patient care side of it. We have been able in this committee, and I think you know how I work with these groups, to bring consensus about, and I think that we can get there.
I have no doubt you will.
Thank you.
Thank you. Michelle Heaton.
Good morning. Again, I'm Michelle Heaton. I'm the Director of Life and Health at New Hampshire Insurance Department. With respect to 480, I understand the motivations behind it, but I'm just a little concerned with the way it's written that there may be some unintended consequences. Part of what prior auth does is it does have a cost containment aspect to it, in that we want to make sure patients are getting the most effective treatments and are not getting treatments that are unnecessary. And by doing that, you bring down costs. But there are also other important aspects of prior authorization, such as patient safety and also just making sure something's going to be covered before you go and have that expense. And I think as written right now, that's where there could be an issue, because as written, it's stating that you can't apply prior auth, but then at the same time saying that the carrier can deny the claim if it finds it's not medically appropriate. So what that will lead to is someone could get a referral to go to occupational or physical therapy. They go and receive those services, and then later the claim is denied because it's deemed not medically necessary. At that point, it's not really helping the patient, because the patient is left in this limbo. Because of contractual stuff, it could be that the provider has to eat the cost of that and can't actually bill the patient. There's a lot of nuances there that we'd have to work through, but I think that's some of the unintended consequences. I think the idea of trying to remove barriers is a good one, but I'm just not sure that as written, this is achieving that purpose right now. I did also want to touch on some of the things that we are doing with respect to prior authorization. So a couple of years ago, we did pass, or you guys passed, a new prior authorization bill, SB 561. That became effective January 1, 2025. What it did a lot of different things, but the big things are it really helped to streamline prior authorization process. So currently, if a prior auth is submitted electronically, the carrier must approve or deny it within 14 days. If it's urgent, it's 72 hours. That has not changed. It's always been 72 hours. And if the carrier fails to act on it, then it is deemed approved. That is huge, because there could have been times in the past where those deadlines maybe weren't met, but there was it still left the patient wondering, well, what am I supposed to do? Now it's kind of closed that, and that if there is no act by the carrier, it's deemed approved, and it's approved, and the patient can go ahead with that care. The other big thing that this bill did is that it opened up peer-to-peer review. So it used to be that you had to wait for the prior auth to be denied, and then the provider could request peer-to-peer to talk to someone about the request and maybe some nuances that didn't come through in the written request. Now, at any point in time, the provider can request peer-to-peer, so they don't have to wait for that initial denial. So we're hoping with these two big reforms that we are doing a lot to streamline prior authorization and remove some of the barriers. There's also some data reporting requirement. The first set of that data will be due, April 1st, and we will be publishing that on a carrier by carrier basis on our transparency website. After that bill passed, we also have been engaged, we've been working on rewriting our utilization review rules to help streamline everything, update them in light of the new prior authorization requirements. And those are going to be entering rulemaking imminently. They have been drafted. They're just in the queue to get on the official rulemaking register. And we can provide those to anyone, a draft of those rules. But they will be entering rulemaking and public very, very soon. So there is a lot we're already doing in this space to try to remove barriers. So I just want to make sure everyone was aware of that, and I'm happy to answer any questions.
Great, thank you. Are there any questions? I think that the prime sponsor has stated her intended goals, so I'm hoping that you can coordinate with her if there's any changes that we need to see on this.
We would be happy to. And also, as those rules go into rulemaking, there's also a possibility we can incorporate some changes into the rules without having to proceed with legislation.
Sure. Thank you. Senator Birdsall has a question.
Just kind of a comment. So I'm a co-sponsor of this, but you know, we have situations, for instance, my situation, it took me 6 weeks to see an orthopedic and another 2 weeks to get diagnosed with a torn meniscus. And that, now you're talking 8 weeks. Finally, I got an approval for physical therapy. And the medication and the physical therapy that I've been getting have been helping it a lot. So, but in that 8 weeks before I got an approval for, I'm limping around and in pain. I just don't understand when physical therapy can actually do some really good work, why we would be fighting not to go into physical therapy and eventually get it just makes no sense to me.
Yeah. And I'm not a doctor.
It's a lot less than actually knee surgery.
Yeah. And I'm not a doctor, but I suspect that in certain situations, until you have a diagnosis or you know what you're dealing with, you may not want the patient doing physical therapy because it could exacerbate the issue. So getting, a diagnosis and making sure you're doing an appropriate treatment to treat whatever the diagnosis is, I think is one of the benefits. Part of what the bill also required is that all services requiring prior authorization must be posted on the carrier's website. So there's a lot more transparency about what requires prior authorization. But I think prior authorization is also only one piece of the puzzle. There are workforce shortages all over the state with respect to all different kinds of professions. So trying to get those appointments is more of a workforce issue than it is a prior authorization issue. There can also be referrals. This bill is not talking about referrals, it's only talking about prior authorization, but sometimes if you need a referral to see a specialist, then you may have to go into your PCP. And there's a lot of other issues that this bill is not going to impact, but we're always, willing to work with all stakeholders to figure out how we can reduce those barriers while at the same time making sure that there's appropriate protections in place.
Thank you. Any other questions? Thank you very much. Okay. We've got a number of people left here to speak. There's just a couple of guidelines as we work through committee rules and guidelines is if you've got written testimony and that's what you're going to testify on, you don't need to read it. Just drop it off and we can read that. So the testimony that you provide, we'd ask you to have it in your own words, summarize it, and hit the main points. The other thing with that is if something's already been said, a point's already been made, you don't need to make that point again. So with that, I'm going to call up Mark Mayu.
So thank you, Mr. Chairman, honorable members of the committee. You throw me a little curveball here because I have a written statement that I would like to go through.
Do your best to hit the good points.
All right, I will.
We can all read here.
I love it. So my name's Mark Mayu. I've been a practicing physical therapist in New Hampshire for over 35 years. My perspective comes from decades of caring for patients and working within the realities of our healthcare system. I want you to consider someone that you love, a spouse, a brother, a parent. They've had an injury or a surgery, and their medical provider offers a referral for physical therapy. The patient comes, they meet with a physical therapist, get evaluated, and it's deemed medically necessary. So now you have two providers that are directly involved with the patient's care, stating that this care is medically necessary. So that's where the recovery should begin, but it's really where the ordeal begins surrounding prior authorization. So before treatment even begins, the care plan is sent to a third-party insurer that the insurer has contracted with to review the claim. The person that has been there for the evaluation may leave the appointment still in pain, still not knowing what they should or shouldn't be doing to care for that condition that they have. They have lots of questions. Their care should be starting then. But it might be 1 week, it might be 2 weeks before you get an answer from the insurer as to whether this patient can participate in care that has been, again, deemed medically necessary by two medical providers. So it's, early on in the stages when this occurs, every day matters. And so then when you finally do get approval, it might be four to 6 visits. By the time those visits are utilized, the whole process begins again. More paperwork, more phone calls, peer-to-peer reviews, simply to continue care for the same condition. This cycle can repeat multiple times. We've seen it. None of this, I would like to stress that none of this is a hypothetical. This is routine. And I see this in my practice every day. So I recognize that your responsibility is to evaluate not just the patient stories, but whether the legislation is evidence-based, fiscally responsible, and appropriately balanced. SB 480 meets those standards. National utilization data shows that approximately 85 to 90% of all physical therapy episodes are completed within 12 visits. So the need to gatekeep those visits is not even really a real thing. It just reflects on how physical therapy and other therapies actually intervene and get patients better and get the outcomes that they need. And these delays in therapy, they're not benign. There's, again, if patients are not getting what they need, there are complications that can occur, and the potential for prolonged disability, higher downstream costs, more medical intervention that needs to occur because they did not receive timely and justified care. So, this, and from our side, as far as what administrative burden itself is a cost. Repeated authorizations, reevaluations, and after a few visits, redundant documentation consume therapy time and medical providers' time. That is unnecessary. National analyses estimate that utilization management adds tens of billions of dollars in administrative costs across the healthcare system annually. So while you may hear concerns that SB 480 can result in increased insurance premiums or isn't needed, that simply is not the reality that we're dealing with here. What we do know is that the current system generates substantial administrative waste and cost that doesn't improve care and delays healing. In a state like New Hampshire, where access to care is already constrained by workforce shortages and long travel distances, delaying medically necessary therapy only compounds the problem and the barriers to patients that they're already struggling with. SB 480 is a measured evidence-based reform. It aligns with typical utilization patterns, restores clinical decision-making to licensed professionals, and puts the patient back at the center of medical care. I respectfully urge you to support this bill, not only as policymakers, but as people who may one day sit, as Senator Prentice has, where they may sit today. So thank you for this opportunity to testify.
Great, thank you very much. You had me thinking you're going to read everything. You did great.
Thanks.
Are there any questions? Thank you very much.
Thanks.
Amanda Packard.
Hi. Thank you all for hearing us today. We very much appreciate you taking the time to do this today. My name is Amanda Packard. I am a physical therapist in the state of New Hampshire and have worked at Portsmouth Regional Hospital for 26 years, caring for the health and recovery of New Hampshire residents. So I will summarize what I have. It's pretty short and I won't overstate things. So I think today what we're talking about is legislation that will help to care and protect the people of New Hampshire. We understand that prior authorization exists to prevent waste and overutilization. The question isn't whether to manage care, but where those controls actually add value. What we've stated and what Mark stated previously is that physical therapy, especially in the first 12 visits, does not meet that threshold. Most episodes of care can be managed within those 12 visits. And the administrative cost of prior authorization often exceeds the cost of the care delays. This makes it an actual poor return on investment, not a safeguard that we think that it's there for. As we know, and it's been said, physical therapy can potentially reduce opioid use, reduced injections and surgeries, and shorten disability claims and work absence. So, I won't give you all of the statistics that we have here because you can read them, but one of the most concerning is that these delays will cause 83% of patients to abandon their care altogether. And this directly worsens clinical outcomes. So again, 12 visits is not a blank check. It's a guardrail against downstream costs. It's not removing the utilization review. It's deferring it to the point when it actually matters. Any one of us here can walk out and slip on the ice. And we need care now, not 2 weeks from now. And we don't need our care interrupted partway through because we were only approved for 4 visits. We need 12 visits, makes sense. and it protects patient access to timely and cost-effective care. Thank you.
Great, thank you. Are there any questions?
Just one.
Senator- Oh, I got Senator Prentice first.
She's first.
Thank you, Senator Avard. Thank you, Chair Rochford. Good morning, Amanda. Thank you
Hi.
for joining us today.
Thank
How
you.
many years have you been practicing?
26.
26?
Yeah.
Wow, thank you.
Yeah.
Okay, so has it been your experience, has been your experience, because it's certainly been mine, that say 26 years ago, a certain type of fall or injury may have gone directly to a surgeon, a specialized, say orthopedic surgeon, where now they're coming as their primary referral and care pathway is through physical therapy and may never end up in an operating room because of that.
Yes, that is accurate.
All right, thank you.
I think.
Senator Avard.
Thank you. Just a quick question on the 83% delays reporting people not, just abandoning their care. Obviously, that could turn into a bad situation for them. But where did you get that figure?
Yep. So the 2025, so the American Physical Therapy Association did a national survey that was just released. And that's where these numbers can be found, is in this big report. So which we can provide for you if you want. It's long, but we can absolutely get that.
Well,
Yes.
of those that did abandon care, were there re-injuries that were part of this? Obviously, something bad could have happened as a result of that. So were there re-injuries or more medical care that was needed after because of the abandonment?
Yep. So, and a related statistic after that is that these delays have shown 65%. So of that, 65% have shown worsened clinical outcomes. And I don't know if some of my other colleagues back here but we have had adverse events happen as well, where people have not received care and have fallen and sustained further injury.
And finally, and so following that logic, so then that would eventually then require more medical care, more insurance coverage, which would, it doesn't seem to make sense. When I look at the fiscal note, it says that it could potentially increase more insurance if we went, costs, if we went with this. But it seems to be counterintuitive. If you're protecting people from re-injury, you're saving, there seems to be a cost benefit with this.
There is a definite cost benefit. That where I said that the first 12 visit doesn't meet that threshold for cost variability, the cost of prior authorization, not just for physical therapy clinics, but for the insurance companies. There are people on the other end that are also having that cost as well. And that physical therapy has one of the strongest downstream cost avoidance profiles in medicine. So what you're saying is that, yes, that prevention, so the early access and taking care of the current injury is cost effective, but also the prevention of further damage, worsening a situation, worsening a meniscus tear that can then deteriorate to the point that now you need a total knee replacement, or somebody who then sustains a fall because their balance is off. It's very much related. So.
Yeah,
Go
thank
for
you.
it.
So prior testimony, we talked about prior authorization and, some of the safety nets with that. But it seems to me that if you're already in therapy, to have another pre-auth seems to be counterproductive as well. But
Correct. So if you're in therapy and you were approved for 4 visits or 6 visits, there's a potential that 1, you already waited for those, and then 2, your care is delayed and interrupted during that, having to go through further authorization processes. As it's been mentioned, schedules are tight, and so your care and getting back into a schedule potentially having to be with another therapist is just not good patient care.
And final,
Yes.
and you heard the testimony again prior to that. Were you comforted the fact that some things and rules are being addressed on this particular issue at all? Did you understand how that she was trying to, a lot of these issues might be already addressed?
It would be interesting to see the details of that. You know, we appreciate any rules that improve transparency and make the process easier. I know legislation isn't always the way insurance companies would like to go. However, the trend has not been in a very positive direction. So this has felt like a safeguard for patients, for our profession, and for cost savings in general. I don't know if that answers
No,
your question.
that's fine. No, thank you. It's streamlining this seems to be, the care seems to be part of the issue for me, and the interruption seems to be a big hiccup. And I'm wondering if we're addressing that fully with this, or if there's something that's already in the pipeline that's rules are ready to be made. I'm just trying to navigate that in my head as we go further with this. I am a co-sponsor, by the way.
Yes, I know you.
Yes. And I think the 12, I know that there's been talk about, but that 12 is a very specific number. And I think Mark gave that statistic that most episodes of care can be resolved in that, 80 to 90% within that 12 visits, which is not excessive. And so that number actually feels important.
Thank you very much. Are there any other questions? Thank you very much.
Thank you.
Tracy Adams.
Thank you very much. I appreciate it, Mr. Chair and honorable senators of the committee. So thank you very much for the opportunity to speak, and I will try to hit highlights and not read my notes as I've prepared them. I just wanted to say that one of the materials that I will leave with the staff is the impact of administrative burden on physical therapist services report that the American Physical Therapy Association has put out so that you can have access to reading that. Amanda referred to some of the information that's in this report for you. So I'm Tracy Adams, and I have been a physical therapist for 35 years, and I have been a therapist in New Hampshire for 11. And I'm the newly elected president for the New Hampshire chapter of the American Physical Therapy Association. So I'm very pleased to be able to, very early in my stay as president, to come before you and just support the SB 480 legislation. I had a few examples of patient care and how the prior authorization impacts it in a negative way. And we have heard from two members on this committee that have similar experiences. And Mark and Amanda have also outlined that physical therapy is frequently delayed because of the prior authorization process and requirements. When I was a therapist years and years ago in North Carolina, frequently patients would come in and they were authorized for 4 visits. And so we would see them for 4 visits. They would need more therapy, and then we'd have to halt therapy while we waited for the pre-authorization to be approved. So this process of getting to therapy with delays and then having the treatment halted for a period of time for further prior authorization is not new and seems to just continue. I think that the insurance representative mentioned that there are some things that are in queue, so they're not available to read. So we don't really know how those suggestions might impact us. But we do know that with the current state of things, our patients are being delayed in getting to therapy, and they are having to have delays during the course of their therapy because of the prior authorization requirements. The state statistic, or national statistic, was that 85 to 90% of physical therapy episodes end within the 12 visits that we currently are asking for. On a local level, the APTA New Hampshire did a pre-authorization survey, and 90% of the physical therapists that answered that survey reported delays in initiating care. So that's very concerning. And 41% of the outpatient therapy practices said that while they were waiting on prior authorizations, the patients experienced an adverse event like a fall or hospitalization. So we're seeking to change that with the legislation SB 480. The other concern that I just wanted to bring up is that on our local survey, we also noted that 80% of the outpatient clinics surveyed said they had to dedicate a staff member solely to dealing with prior authorizations. Smaller clinics, rural area clinics, they might not be able to dedicate one staff member or more to deal just entirely with prior authorizations. They may have to kind of redirect their resources and their staff to deal with the prior authorizations, and that would limit, once again, the ability to apply direct patient care. So this bill, we're just trying to look for, understand payer oversight and insurance companies' concerns, but the clinical reality is that we would like our patients to have timely access to care without interruption, and that we would appreciate the fact that this bill would also take away some of that administrative burden that is taking away resources from patient care. So thank you for supporting this bill, for sponsoring it, co-sponsoring it, and we thank you for the opportunity today.
Great, thank you. Are there any questions from the committee? Senator Prentice.
Thank you, Chair Rochford. Tracy, thank you for coming to speak to us today. Workforce, pre-COVID, post-COVID, has there been a shift in your profession in either the number of physical and occupational therapists that are entering or their practice patterns?
I think that we have seen a change in the workforce for sure. After COVID, I think we've lost some people, and I think that we are slower getting new therapists out into the practice. So that is impacting the workforce in general. And then trying to attract the therapists that are available to come to New Hampshire is sometimes more of a challenge than we'd like it to be.
Well, just quickly, so considering that, because I'm thinking back on I started to say it when I was introducing the bill, that my pre-COVID experience was that if I needed to see a physical therapist, I barely got out of the parking lot after I saw my primary care provider and I had an appointment. Now, not the case. So does the stress of the workforce issue compound the situation with managing how long people have to wait if they get, say, moved out of care waiting for a new authorization?
I'd have to say that it's a piece of it, yes.
Okay. But I think we've got some solutions and work we can do.
Yes, and thank you so much for being willing to work on those solutions and for all the parties that are involved to try and come to an agreement on something to move things forward so that patients have better access to care without delay and that we don't have the administrative burden holding back our ability to take care of people.
Okay. I'll just say that not just working with the care providers, thank you, Tracy, but it's been my experience that we can work, we worked with the plans to try to find
Absolutely.
a good place, and I'm looking forward to that.
Thank you very much. Thank you all.
Actually, we've got one more question from Senator Long.
Thank you, Mr. Chairman. Are there any pre-authorizations that say 4 days? However, if you feel it should be extended, we'll give you another five days. Are there any authorizations that do that? The insurance companies?
I'm personally not familiar with that. Typically, it's you are authorized for another, say, 4 to 6 visits.
Okay, so if I could follow up, so the original 4 days, you have to get the pre-approval. It's not, if you believe this is working and we would need another 5 days, you're allowed to go another 5 days. They would do that earlier. You're saying no, they wouldn't do that earlier.
Typically, at this point, you would have your evaluation, and then you would have authorization for 4 to 6 visits. Then when you get to the end of that 6 visits, if you feel like more therapy is required, then you would have to do a reevaluation and turn in all of that paperwork again and wait for the next approval, which could delay care where patients, can't be seen until they get that second authorization.
Great.
Thank you very much.
Thank you.
Sarah Avard.
I do have a question now.
Oh, yes, sir.
Slow processor. So who's mandating the 4 to 6 days? Is it the doctors or is it the insurance department?
The insurers will all give us the number of visits that are authorized, and then we work within that.
So they're practicing medicine through, basically, through telling you how much is covered and how much is not.
They give us that as our starting point, yes.
Thank you.
Thank you.
Senator Birdsell. No, don't go anywhere.
I'm so sorry. I'm so sorry.
No, I don't have a question, but you had asked about the, you hadn't heard about the changes that are coming. It's Senate Bill 2024 Senate Bill 561.
561.
If you want to get on the General Court's website, it shows it up there and you can go through it and see what changes are being made.
Thank you very much.
Yep.
Being more educated is certainly a huge part of this. Thank you.
Any other questions? All right, now you can go.
Okay, thank you all
right.
very much.
Lynn Maloney.
Good morning, all. Thank you for allowing me to speak in front of all of you, and I appreciate all of your support so far on putting this bill forward, 480. My name is Lynn Maloney. I'm a physical therapist, and I've been licensed in this state for 41 years. I've worked in this state for 32 out of those 41 years, but I kept my license the whole time. So I come from a rural hospital in southwestern New Hampshire. I wanted to not add on to the things that my colleagues and peers have already talked about, but to give a real life example, kind of more focused on what Michelle from the Insurance Commission group talked about, is the legislation that went in earlier this year, hoping to improve or limit some of these pre-authorization and administrative burdens that we've gone through. July 1st, one of our local insurance companies here in the state made a change in site of service. And that's another whole discussion, okay? Not going down that road right now, but talking about where patients can access their physical, occupational, and speech therapy services. And from what I understand, the goal is to move people away from perceived higher expense care in a hospital setting versus going into a private practice that is contracted with their services through that insurer. 2/3 of the state is rural. There's not a private practice on every corner for patients to access. So here's my example. So we can get to do, the patient gets referred to our outpatient physical therapy in our hospital settings from a local provider. Patient lives in our area. They come in, we give them an appointment, we verify that they have this certain insurance. Depends on that particular plan within that particular insurance company. So then we do the evaluation. We have to then send in the authorization paperwork to that company to find out. So then they will say to that patient, here are 3 other options that you can go to if they are within a geographical area of that patient. They may or may not be vetted as appropriate. But again, I don't want to get into the site of service situation. That gets into that. But most of my area in southwestern New Hampshire does not have any other options for patients to go to under this insurance company's plans. There just simply are none. When that insurer gives authorization to patients to go to those private practices or to a hospital site of service meeting their criteria, those patients are given 12 visits. If they are in the rural hospital setting where we don't have any other option, there's no other option for that patient to go to, the hospital is given 5 visits. That whole process is done manually. It is not anything that we can continue online. Their third-party vendor does not have it set up so that we can do all this administrative burden online. We have to make phone calls. We have to fax. So just by the fact that we are a rural hospital, rural part of the state that doesn't have these other options for our patients to go to, we are put into this administrative burden basket of rinse, slather, repeat constantly. And it's not automated, and it's through a third-party vendor, so that is increasing the cost. As an administrator in my hospital, for my rehab department, I am adding more staff hours and more staff almost every 2 months to keep up with this process. Even though some of those things have gone into place, it's just, somebody's getting through another corner or another, Swiss cheese hole, loophole in the process. So I just wanted to give that example from a different perspective of just the inequalities in the state as far as, people having access and the number of visits they're allowed to get based on different insurers' plans. I just wanted to say that, and thank you for listening and your support.
Thank you. Are there questions from the committee? Senator Long.
Thank you.
Thank you, Mr. Chairman. Just, you may not know this, but is there any data showing urban and rural timeframes?
I don't have that.
That was a good point you brought up. Do you know if there's data on that?
I would have to look to my APTA colleagues and others. I don't have that per se. I just have more personal experience and just knowing that 2/3 of the state is considered rural, and rural health is a big conversation. And that just also limits access to care.
Thank you.
Thank you.
Senator, did you have a question?
No.
Oh, all right. Any other questions? Thank you very much.
Thank you.
Miles Morneau. All the way down from Littleton.
I apologize. That was marked in error, so I didn't have actually anything.
Oh, you can talk if you want. You came all this way. If you don't, I won't hold you to it. That's fine.
I would just like to echo everything that my other colleagues have said. I think especially up in Littleton, we are in that rural region as well. And so the hardships that we face as a critical access hospital and the rehab department in a critical access hospital that we face with this administrative burden is really taxing on our staff and our therapists. It takes away from patient care that we have, because we have therapists that after 4 visits, they're having to submit more paperwork. And then if they have to then also do a peer-to-peer review, they're scheduling that peer-to-peer review during their lunchtime when they should be actually taking the time away from their job, but there's no other opportunity because patients need to be seen. So thank you for your time.
All right. Well, thank you very much. Let's see. Sabrina Dunlap.
Good morning, Chair Rochfort and members of the committee. My name is Sabrina Dunlap. I'm Senior Director of Government Relations for Anthem Blue Cross Blue Shield in New Hampshire. Thank you for the opportunity to testify in SB 480. We have had several very good discussions with Senator Prentice about this bill, and we are absolutely happy to work with stakeholders, but we are opposed as it is currently written. And the primary reason is the bill interferes with our current utilization management program for PT, which is a dynamic process tailored to each patient's needs. Basically, how it works is there's no prior auth for the first visit. After the initial visit, a provider enters information. It's pretty limited information, and they get a tailored number of visits back based on that patient's clinical needs at that time. I believe it's usually ranging from something 4 to 30. In case the provider thinks the member needs more visits, they enter more information into our system. This is largely digital, I think exclusively digital, and get the extension for more visits. My understanding is this is a simple process and none of the above requires any upload of clinical documentation. The problem with bills like this, and we've seen a very similar bill in Maine, so it's essentially a cap on prior auth, it basically mandates us to incorporate the cost of 12 visits into every member's plan. So that does drive up premiums. So even if people don't use that number of visits, we have to build that into the plan for everyone. So in Maine, the legislature passed a similar bill in 2023, removing any prior auth for the first 12 visits. Prior to that legislation, our program was effectively managing utilization from the first visit on and minimizing unnecessary care. Comparing 2023 to 24, After the legislation, we saw a significant increase in cost because this is essentially a mandate for 12 PT visits, which is not always appropriate. We often hear the argument with this type of legislation that by not having prior auth requirements on the first 12 visits, you will see a decline in other more costly services like surgeries and injections. However, analyzing Maine's data, we did not observe any reduction in high-cost interventions such as surgeries and pain injections, despite the increased physical therapy services offered to our members in Maine. So I would flag, this bill would only apply to the fully insured market. I know that you have heard this before, but it is just a fact that a significant number of people in New Hampshire have self-insured plans. This type of legislation does not touch those people. So some of the issues that were raised by the prior testimony, it's possible those sorts of things that PT people have raised as issues could just continue if somebody has a self-insured plan. I would definitely be curious to hear more about some of the issues that were raised. We do not see prior auth as a barrier to care. We do not want it to be a barrier to care. It is part of the foundation of our managed care system. It is highly regulated, as was mentioned. There was significant reform passed very recently. I don't have the exact turnaround times for PT/OT, but I could get them. In general, our turnaround times are very fast. We want them to be fast. We do not want to see barriers to care. We do not want to see disruptions to care. And in general, we don't. I would just finally flag some of the issues with the actual language. There's language at the beginning of the bill saying this is including but not limited to PT and OT. That is very broad and very vague, sort of never ending. I would also just flag the effective date, 60 days after passage. Very difficult for us carriers to implement things that's mid-plan year. So just wanted to flag those things. And I think that is all. And thank you for the opportunity to testify. And I'm happy to take any questions.
Questions from the committee? Senator Bertzel.
Thank you, Mr. Chair. Thank you for taking my question. What are your thoughts about on why, from the testimony we heard, why rural hospitals, PT organizations would only get authorized 5 visits versus more populated areas they would automatically get 12?
Thank you for that question. I'm not aware of that from Anthem's perspective. So I don't have thoughts on that because I just don't know if that's actually something that is true for us.
Senator Prentice? Oh, yeah.
Well, if I may, and then, well, I'm not the chair, but maybe Senator Long can go next. Thank you, Sabrina, for taking my question. And I know, you stated we've already spoken. There's some things certainly we need to work on, and hopefully we can get to go. But you just brought up this online between 4 and 5, including but not limited to. So, and I know this is just one thing, but you want to see that. So it just focuses specifically on physical therapy and occupational therapy, removing, what would the but not limited to potentially, what could that be?
Thank you for the question. It's just that prior to that, it says rehabilitative or habilitative services. I don't know off the top of my head. I could certainly look into what other things that could encompass, but it just, when I see including but not limited to, and then a short list, it always gives me pause because it's hard to know where that list ends.
Okay, right. Thank you.
Senator Long.
Thank you, Mr. Chairman. So you mentioned fast authorization process. What is fast? 2 days, 3 days?
Oh, thank you for the question. Yes, I'm digging deep now. I'm sorry, I can get you more updated stats, but when we worked on the prior auth bill a couple of years ago, I recall that for digital, so people use our digital system, the turnaround time is often within minutes. And certainly under law, we're required, I think it's 7 days and 14 days, depending on if it's digital or paper. But when I've seen numbers on it, we are well within that and usually much faster than that. So.
Very good. Thank you.
Thank you.
Are there any other questions? Senator Prentice.
Thank you. Thanks, Sabrina. So you mentioned your dynamic, it's something we talked about, but you brought it up here too, the dynamic utilization process, the way that you manage this. So, and that's specific to Anthem, and maybe if Paula Rogers is going to testify, I can ask her this question. But how many other companies, because we know it's not just one insurance provider. How many other companies use a similar plan? Because there are different, I mean, we know going into this that there are differences. So that's what I'm trying to balance.
Thank you for that question. This is just my best guess, knowing what I know about insurance companies. My guess is that the other major carriers have something similar because we want to make things more seamless. We want to speed things up. We want to reduce barriers. So my guess is the other carriers probably have something similar to what Anthem has. That's just a guess, but.
Thank you.
Thank you. Any other questions for Sabrina? No? Thank you very much.
Thank you.
So Paula Rogers.
Thank you, Mr. Chairman, members of the committee. For the record, my name is Paula Rogers, and I'm here on behalf of AHIP, America's Health Insurance Plans. And I've been sitting here and listening very carefully. And I've thought back because I've been here and not here over a period of years. And I remember the first flurry of PT concerns in the Commerce Room, maybe 15 years ago. And then very quiet after that flurry of activity. And I was thinking, well, what happened after that flurry of activity that sort of settled things down? I don't really have the answer to it. But I have had, like Senator Bertzel and Senator Prentice, an issue that required me to go to PT. And I can also tell you that it saved whoever was insuring me at the time a lot of money, because I had a physician suggesting surgery, and I was reluctant to do that, so I went to PT. And Maggie, who took care of me, is on my mind as I was shoveling snow yesterday, because I know the exercise that I'm supposed to do, and so whatever herniated disc I have, it just sort of settles right down. So I can tell you I like physical therapists. So I'm listening to them here today, and I sense their frustration. So I'm saying to myself, well, I was away for 2 years, and during that period of time, and the department talked about it, there was a lot of work done, and strenuous work about prior authority and prior authorization and the standards for it. And in fact, in the Commerce hearing last week, I believe it came up in Chairman Hunt's committee, that somebody was introducing this expansive bill to look at all managed care in New Hampshire by the insurance department. That would have been a gargantuan undertaking. And it winnowed down to the point where it seemed to be about prior authority. So I'm reminded today that at the beginning of this past year, the prior authorization bill that came out, and is touted here as being an improvement, is now required, and carriers are, I assume, responding to it appropriately, and they do have reports to make to the insurance department. But maybe there's some unevenness, because in the Commerce Committee, there was a young doctor that was there, and he was wanting to do knee surgery, and he was complaining about the fact that when he went online to look at the carrier's explanation about how you do prior auth for their company, he wasn't getting the response he expected. So there may be a lot of that, and I suspect with physical therapists, they're encountering it on a regular basis, because I understand right now, most carriers will let you go to a physical therapist without referral, but then comes the prior authorization once they have the plan that's going to envelop this particular patient's care at that particular facility. So I see a lot of things going on. A change in the fact that there are physical therapists here very concerned, but Senator Prentice picked up another element that may be part of this delay that is now ascribed entirely to prior authorization, which is maybe workforce issues. And that was alluded to in the discussion of a prior physical therapist who was testifying. So what I'm saying is we have some better communication to do. And I think when the meeting began, there was a sense that there would be an opportunity for stakeholders to sit down, including the insurance department. They have the prior authorization obligations. The carriers that could engage in those discussions, and most importantly, of course, the physical therapists. So I think discussion needs to be had. I think Sabrina Dunlap brought up some, if you looked at just the legislation that was introduced, there are a number of things that can be done to make it look better. Perhaps there are different timeframes. Perhaps there's something agreeable that could be done. And I certainly would like to participate in that situation if it eventuates after this hearing.
Great, thank you. And I think Senator Prentice will be leading that charge. Are there any other questions from the committee? Thank you very much. Danielle Amaro.
Okay, as long as we're all safe, right? Thank you so much for the opportunity to speak. I will not repeat a lot of what you've heard, but I did want to register support from occupational therapy. I'm an occupational therapist. My name's Danielle Amaro. I've been working in the state since 1995. And I've served in a variety of different positions from clinician to management. Now I'm faculty. I'm the co-legislative chair, and my other co-chair is here, Heather Gilbert, representing New Hampshire Occupational Therapy Association that does support this bill. One thing that I haven't really heard spoken to is that OTs, PTs, and speech therapists are bound by ethical obligations to provide medically necessary treatment. And we know that, and we know what medical necessity requires. So I do think I would like to just say that we understand when we evaluate a patient what constitutes therapy that's appropriate or inappropriate. And there is a burden on the therapist to make sure that they're providing therapy that is appropriate and would fall within those guidelines that would allow for pre-authorization. My personal experience is I had surgery 7 weeks ago today on my foot. I have a whole lot of screws and a plate in there. And I had enough notice that I got into PT in a timely fashion, but the clinic I go to doesn't schedule a second visit for at least a week past the first visit because they need to allow time for pre-authorization. So this is my second go around because I have 2 feet, but I know what I'm needing to do, but that means my next appointment's not until next week. I actually went in the snowstorm on Monday to start my therapy because I knew I couldn't go back for a week. And also to speak to the whole process, peer-to-peer, I did hear therapists are taking up their lunch times because you can't compromise patient care by not having a therapist available for patients so that they can spend time on the phone. If pre-authorization for some reason didn't come through in a timely fashion, then somebody needs to be there canceling and rescheduling these patients. And a lot of times when you cancel a patient is where you lose them to care. If you had to call and leave a message because they're working, we can't see you tomorrow, we're waiting for your insurance, please call us back to reschedule. Sometimes they just never do until they have further complications. My background is as a certified hand therapist, so that's also orthopedic in nature, but that definitely applies to some of our neurologically impaired people that we're seeing. So I just want to put in our support and say it's happening to occupational therapists as much as it's happening to physical therapists. And it does feel like a burden, the pre-authorization process. And personally, I've experienced that it does kind of put wrinkles into care. I'm happy to take any questions.
Great, thank you. Are there any questions? Thank you very much. And the last person I have signed up to speak is Peter Bragdon.
Thank you, Mr. Chairman. I'm always worried when I see Senator Prentice talking as I come up. My solution for the shoveling snow issue is I resolved I am not going to shovel snow again this year at all, no matter what happens. So you may not see me next week. Thank you, Mr. Chairman, members of the committee. For the record, Peter Bragdon, representing Harvard Pilgrim Healthcare, New Hampshire's not-for-profit health insurance company. It's great to hear the testimony of people and the actual stories of how their interactions go. I signed up and opposed the bill, at least as written. Our biggest concern is some of the language we feel is overly broad, and Sabrina had mentioned this, that there's some language in there, I think it's page or line 4 and 5, talks about basically shall require prior authorization for all rehabilitative or habilitative services, including but not limited to physical therapy and occupational therapy. If the bill was limited just to PT and OT, that would be one thing. But to make a very broad statement about term that isn't necessarily defined in statute, and people may have different ideas of what that means, or some new expensive type of service comes around, and we have no ability to have any say on that, where there might be less expensive things available. So I think it's a known issue with the PT and the OT. I think it's been described very well. Our big concern is the language there is so broad, it could open it up in the future to things that that we'll have no control over. So if you could take that into consideration, and happy to have those discussions as well. And that's all.
Great, thank you. Are there any questions? Seeing none, thank you very much. Thank you. Is there anyone else that has not signed up that would like to speak on Senate Bill 480? Oh, Cam.
You know better.
Thank you, Mr. Chairman, member of the committee. For the record, Cam Lapine, I work at Orin Reno. Here today representing Cigna. I did not sign up. I am just answering Senator Prentice's question about Anson's practices involving their dynamic, what'd you call it, a dynamic review. So I immediately reached out to Margaret Reynolds. Our policy states a physical therapy evaluation is considered medically necessary for the assessment of physical impairment. So they would have to have a first visit with a provider in order to assess their condition, in order to determine how many visits would be covered. So similar process.
Senator Prentice.
Thank you, Chair Rochford. Thank you, Cam. Quick question on top of that. So the initial, after the initial evaluation, do you have a cap on the number of visits?
I don't have that in front of me, but I will certainly get back to you.
Okay, because I know that there are differences, and I think that we're going to have to list them all out. Thank you, Cam.
Are there any other questions for Cam? No, thank you very much.
Thank you.
And Michelle, I did have another question for you, if you could come back. It won't take long, I promise.
Always happy to help.
We've been talking a lot about the rules coming from Senate Bill 561. You said the rulemaking is coming soon. I'm assuming that's when you start, or do you have something?
No, it's already
rough-
drafted. We're just going into the process. I believe we're waiting for the fiscal note.
Is there?
It's fine.
All
We
right,
can
yeah.
share
I was
it,
gonna say,
yeah.
if there's we could get a sneak peek on that just to take a look at.
Yeah,
that.
we can circulate to everyone. It's going to be published very soon, but we can give you the preview.
All right.
Yeah.
If you could send me a copy, because I won't look at the website. Thank you very much. Okay, there's no one else that'd like to speak on 480. I'm going to close the hearing.
Okay. Did we change the sign? All right. Your salary's on the line here. Yes, neither do I. As soon as you put that sign up, we'll head it up, get going. All right, we're gonna open up the hearing to SB 646FN and hear from the prime sponsor. Welcome.
Wait, 646 or
Oh,
550?
I'm sorry, which one is it? 550. That's the one I meant.
All right, I've got to make sure I got my right notes here.
550FN.
All right, for the record, my name is David Rochefort. I represent
These were back.
Senate District 1, and rather than list off every town I represent, because it's far larger than what this bill is. This is a one-word bill here today. So this bill is relative to insurance coverage for services provided by naturopathy providers. And just to give you a little background on why I got into this, we have what we call a healthcare system in the United States, in New Hampshire. We don't really have a healthcare system. We have a sick care system. So I got involved working with these professionals in my professional life because these folks are actually involved in healthcare. And naturopathic doctors are trained and are specializing in really, in my experience, preventing disease and treating disease at its start. What this bill does is we do have insurance coverage for these providers in the state of New Hampshire. Several years ago, there was a mandate, and I'm going to make no bones about it, this is a mandate, that said individual plans may or shall provide coverage to these folks. But as we look at the text, group plans may provide coverage for these providers. This bill just changes the may to a shall, and will allow group providers to cover these benefits. Now, again, understanding that it's a mandate, I reached out to insurance last week and inquired about a mandate review process. The mandate review process, I was told, costs about $20,000 to $50,000 for the state to undergo that. But this is such a small number of providers, I didn't feel that that cost warranted what this bill would do. There are only 25 naturopathic doctors in the state that take insurance. And if you look at the fiscal note, that reiterates the fact that there's going to be a very small number of providers that will be covered from this. And the department also recognizes the fact that with this one word change, the health carriers still will retain the authority to apply standards for medical necessity, credentialing, and contracting within the plans. So this isn't throwing the gates open, looking for we're looking for radical changes. This is a very small, minute change. There are a number of states that do mandate this. And from what I've been told is the mandated states have not increased premiums, but have increased access to care. And again, many of these providers are primary care providers. They treat people with ongoing chronic conditions, and they are reimbursed, or they are considered a mid-level provider. So again, reimbursement is at a lower level than an MD, let's say. So that's the overview of the bill. I'd be happy to answer any questions if you have any. And I think there are some folks that are signed up to speak on this.
Questions from the committee? This will cover state employees as well?
That's a good question. I don't know if it would cover state employees. I don't know if that's considered.
I'm getting a no.
All right.
Thank you.
I was going to let them talk to that.
Yeah, absolutely.
All right. Thank you. I need a rear view mirror back.
Yeah. Michelle, if you wouldn't mind coming up after seeing how no further questions.
Hello, my name is Michelle Heaton. I'm Director of Life and Health at New Hampshire Insurance Department. This bill is amending language only in 41518, which is specific to group health insurance. So it would not apply to any self-funded plans, the state plan, Medicare, Medicaid, all of those plans outside of our regulation. This is what we would call a soft mandate. It's attempting to mandate something, but it's really kind of related to naturopathy providers and not necessarily any particular services. So in that respect, it's not a true mandate, because a true mandate is mandating specific services, whereas this is just stating that if naturopathy providers are providing covered services, then they shall be covered. We had prepared a fiscal note for this, but I believe OLS is just a little behind because I'm not seeing it in the text here. And we estimate that because it's not changing the covered services necessarily, there would be a minimal impact. There could be a slight increase in services to the extent that they become more available, but it would be small to indeterminable. And I'm happy to answer any questions.
Great, thank you very much. Are there any questions? Thank you. Let's see, Nancy Cassidy.
Hi, I'm Nancy Cassidy. I'm here in support.
Yeah, you can turn your microphone on. Yes. Yeah, that's that gray button right there. Thank you.
My name is Nancy Cassidy. I'm here today in support of SB 550. For years, I wanted to see a naturopath doctor, but being on New Hampshire Medicaid, it didn't allow me to. In 2016, I had emergency surgery at a local hospital. Nearly 7 months later, excuse me, I was admitted to the same hospital for yet another surgery. It turns out that the first surgery was a case of medical malpractice. I almost died at the hands of the same hospital that brought me into this world. Excuse me. After what I went through, I knew I had to seek alternative care because Western medicine had almost ended my life. So I searched and found Dr. Michelle Haff and began seeing her in February of 2020. At this time, I was paying out of pocket for me and my twins, and it was expensive. But to me, it was worth it after all we'd been through. For nearly 7 months, I paid out of pocket anytime we needed to see her. I ended up getting married, and my husband's private insurance allowed me to see Dr. Haff more frequently. After years of being dismissed by traditional doctors about my thyroid, Dr. Haff tested my thyroid and discovered I had Hashimoto's, an autoimmune disorder causing hypothyroidism. Without naturopathic care, I don't believe this would have ever been discovered. Having my private insurance cover naturopathic care has also allowed me to have acupuncture sessions multiple times a month, as Dr. Haff is also a certified acupuncturist. This has helped me with pain, anxiety, depression, and even lightened up my abdominal scar left from the 2017 surgery. Without my private insurance covering naturopathic care, I could have never afforded to have so many visits with my doctor. I am now divorced and will lose my current private insurance at the end of 2027, but I will be looking for new insurance that I hope will cover my visits with my naturopathic doctor because you chose to sign this bill into law. Thank you. I'll have any.
Thank you very much for your testimony. Are there any questions? Thank you very much for coming in today. Sabrina Dunlap.
Sorry, Senator, I didn't think I signed up on this one.
You did, unless you want me to check you off. You said,
okay. Well,
speaking and neutral, so.
Okay, I will just briefly say Sabrina Dunlap, Director of Government Relations for Anthem, and I was I think, going to flag that we were neutral because we already cover naturopathic services, so.
Great. Thank you.
Thank you.
So I've got Dr. Haff and Dr. Matheson, both from hand to hand. Do you want to come together or separately? Separately? All right, we'll call Dr. Haff first.
Good morning. Chairman Rochford, thank you for your.
Oh, you got to turn your microphone on. Yes, thank you.
There we go. Okay. Chairman Rochford, thank you for your sponsorship of this bill, and to all the members of the committee, thank you for your time this morning.
My name is Dr. Michelle Haff. I am the president and legislative chair of the New Hampshire Association of Naturopathic Doctors. We are a professional organization, and we represent the 150 licensed naturopathic doctors in our state, and we support this bill. As Senator Rochefort explained, since 2013, we have had mandated coverage of individual insurance plans, but it has been optional to cover naturopathic services under group plans since that same time. And this has created a large gap in accessibility to naturopathic medicine. Only 5.5% of New Hampshire residents have individual plans that will cover naturopathic medicine, while 55% of people have employer-sponsored plans or group plans, and those plans may or may not cover our services. Harvard Pilgrim covers NDs under individual plans and group plans. Cigna does elect to cover us under group plans. Aetna covers us, but they only credential a certain number of naturopathic doctors. Anthem covers us under individual plans as mandated, but group plans are plan dependent. So there has to be a rider that says that that plan will cover naturopathic medicine. United Healthcare doesn't cover us, but sometimes they reimburse us at a lower rate from through a third party. So if this situation sounds very confusing and inconsistent, well, it is to everyone involved. And imagine being a patient trying to navigate the insurance world while just trying to find a provider for the type of care that they prefer. We are a small profession, as Senator Rochefort mentioned. There are only 25 of us who are taking insurance in the state currently, but we expect that to change. The confusing situation around insurance has been discouraging for certain NDs to take insurance, but once it's more straightforward, we think that they will enroll in insurance, and it will draw naturopathic doctors to the state, which will help drive down the healthcare provider shortage. And keep in mind that even though there's a small number of us, this would impact thousands and thousands of patients positively. The current patchwork of coverage creates a lot of administrative burden for everyone, for patients, billers, providers, insurance companies alike. We have a patient who's going to testify to that effect, where you can see just how confusing it is and onerous and costly with the back and forth of that. But passing SB 550 is important for other reasons as well. People want this medicine. Use of naturopathic medicine has quadrupled in the last 20 years. And in other states with full coverage, insurance companies market this benefit to employers and to patients because of its appeal, because it saves employers money. My colleague will testify about naturopathic medicine being cost-effective medicine. As Senator Rochefort mentioned, in other states where there is comprehensive coverage of naturopathic medicine, premiums have not increased. We, in fact, estimate that this bill would save insurance companies $20 million a year, and that's a very conservative estimate. And the reason for this is because we provide preventive care and lifestyle medicine. And so what that does is we prevent and treat chronic disease very well. And 90% of healthcare expenditures are for chronic disease. We use low-cost, non-invasive, whole care root cause medicine, and that drives down costs. And then lastly, I just want to address the idea of a mandate. I'm glad to hear it's not a true mandate. But I wanted to point out that every other major type of healthcare provider does have mandated coverage of group and individual plans in New Hampshire. Acupuncturists do not. But aside from that, MDs, DOs, PAs, APRNs, chiropractors, certified midwives, podiatrists, ophthalmologists, or optometrists rather, they all have mandated coverage of insurance for both group and individual plans. So we just believe that we deserve equal treatment to other healthcare providers for group coverage. Licensed naturopathic doctors have been licensed in New Hampshire for 31 years, and we've been taking insurance for over 13 years. And we provide a very valuable service to thousands of residents in our state, which benefits patients, employers, and insurance companies. So we would really appreciate your support of SB 550. Thank you.
Great, thank you. Are there any questions? Thank you very much.
Thanks.
All right, Dr. Matheson. It's good to see you again.
Thank you for letting me speak today. It's a privilege. Just want to add a little more input on top of what Dr. Hoff spoke about. As we heard, 90% of the healthcare expenditures in the US are for chronic disease. And really, naturopathic doctors are best suited for addressing this epidemic. At least 75, I'd say 75% of the patients that I've seen over 22 years have had a chronic disease. And most of them have been to 3 to 5, even more other doctors before they show up in our office, multiple specialist visits, and they're often really, really frustrated. So we're in a good position because of our training to address this issue of chronic disease. We often treat, just to add a little human perspective to this, we often treat people that conventional medicine has given up on. And that's not a good feeling if you're a patient. And we do it in a cost-effective way, as Dr. Hoff mentioned, for insurance companies and for the patient. So we have a big reference sheet that you can look at. I won't read you the studies, but we have multiple studies that prove what I just said. So that's not just me saying it. Much of the chronic disease epidemic can be addressed by lifestyle and dietary changes, stress management, and NDs are really extensively trained in this area. One of the core precepts of our medicine is that doctor in the Latin actually means teacher. So we do teach. We spend time with our patients. We see fewer patients daily. We've made that choice as a profession. We don't know any other way to do it. So we have longer visits, yes, but we save money on the back end because we prescribe less medications. We tend to use low-cost therapies that actually do not increase the burden to insurance, like nutrients and botanicals that are not covered by insurance. So the insurance companies do not see the bill for the pharmaceuticals. We don't use them as much, although we can prescribe and we're trained in pharmacology. So we kind of straddle both worlds. But we often go for the low-cost interventions like botanical medicine and nutrition. NDs practice very safely. We get very, very few complaints coming through our licensing board. So that's one thing to be aware of. We tend to use less imaging. I think like MRIs and CTs and so forth. We use them when needed, but a lot of times just by doing a more extensive history of the patient and talking to them and hearing their story, you can rule out the need for an expensive imaging. So I don't know how much those cost, but we save a lot of money that way for everyone involved. In 2012, I initiated the process of this original bill, which we're trying to amend. And since then, as Dr. Hoff has stated, we're thankful that we have some insurance coverage, but it's created a real administrative burden in our offices. We can't tell anybody that they definitely have coverage. And so often they'll call their insurance companies, they'll be told they do have coverage, and then in the end they don't. So it's very confusing for everybody involved in that process. Another point too is that we always see patients that are saying, it's so hard to find a doctor that's taking new patients. Well, here we are, we're here. Sometimes we're kind of invisible, I think, in this state, but if we could level the playing field with insurance, we're waiting. We're waiting to take those patients that can't get in anywhere. And as Dr. Hoff said, we're really the only class of doctors that don't have mandated, sorry for that word, insurance. And there's no reason, there's no good reason for that at all. There really isn't. We're trained as primary care doctors, and we should have equal insurance. So another point too is that people are looking for it. So it's a good marketing opportunity for insurance companies because people want this coverage and they're looking for plans that have it. So thank you for hearing me out. I really appreciate the opportunity.
Great, thank you. Are there any questions? Thank you very much. Thanks for coming in.
Thank you.
Maria Campbell.
Hi, my name's Maria Campbell. I want to thank you guys for your time today. I am a brand new patient of Dr. Matheson's. I have been dealing with a chronic illness for 4 years now. And in the beginning, I saw doctor after doctor, specialist after specialist, tried many different medications. My chronic condition remains undiagnosed with no answers, but a lot of suffering. And that suffering affects my job, my relationships. I'm not able to work as many hours as I used to be able to. Therefore, I don't make as much money as I used to. 2.5 years ago, I got married, and when I got the health insurance plan for Blue Cross Blue Shield through my husband's work, I was no longer bothering to see doctors at that point because I wasn't getting anywhere. And so I thought with this new insurance plan, maybe I could look for a naturopathic doctor that might be covered. And they initially sent me an email that had a list of naturopathic doctors that I might be able to see that were unfortunately nowhere near where I lived. And so fast forward to just by chance finding Dr. Matheson's office and being told that they accept Blue Cross Blue Shield, and not thinking that I had a chance of still getting covered, but deciding, you know what, it's worth a quick phone call. I called my insurance, I believe it was December 6th of 2025, and they told me, in fact, that I would be covered. And I was so ecstatic, and I had not seen a doctor in quite some time. So I set up my first appointment with Dr. Matheson for January 5th. It was the best appointment that I've had in a long time, and I really have enjoyed, even though it was just the one appointment so far, enjoyed everything that I heard and the plan that was put forth. The next thing I needed to do, though, was find out what my insurance would cover for the blood tests that were going to be required. And I knew all of them might not be covered. So I called my insurance to find out what may or may not be covered. Unfortunately, not only did I get the answer about the tests, but I found out that the information that they had given me on December 6th was incorrect. And in fact, that I would not be covered to see Dr. Matheson at all, and that they were now charging me $350 for that first appointment that I had already had with him. By the end of that phone call, they said that they would be getting back to me within the next week on whether or not they would reimburse me for that first appointment so that I did not have to pay the $350. However, my plan does not cover naturopathic care, is what they told me that day, which is mind-blowing because 2.5 years ago, you sent a list that had naturopathic doctors on it, just not in my area. A month ago, you specifically told me he would be covered. Now you're telling me he's not going to be covered. Your plan doesn't cover naturopathic care. And now they'll get back to me and let me know whether or not they'll reimburse that first appointment. But of course, that won't cover any future appointments. So now I've not even been able to proceed with the blood work, except for one that was covered by insurance, the rest are not. I need to know where I stand financially. I'm not making as much money as I used to because of all of this in the first place. So I need to know where I stand on the first appointment not being covered, on what I'm going to have to now pay out of pocket every time to see him in the future, plus the additional costs of all the tests and any medication, supplements, things like that that I might need. So it's been very overwhelming, very stressful, and 4 years of already dealing with the issues that I've been dealing with and dealing with the suffering that I've been dealing with. It's just unfortunate to have had to have that added on top of it, and that I can't just get the type of care that I think actually would have helped me. So thank you for your time and listening to my story. I appreciate it.
Thank you, Maria. Are you available for questions? All right, Senator Birdsall has a question.
Okay.
Thank you
Yes.
for taking my question. So 2.5 years ago, I think you said Blue Cross Blue Shield sent you a list of the
Naturopathic, yes.
naturopathic doctors. Is that the same coverage that you have? Was that under your husband's coverage?
Same, as far as my knowledge, the plan has not changed. So I married him in September of 2023. And within the first couple of months, I reached out to them asking if there was any naturopathic doctors that would be covered. They sent me a list, and the list that I looked at had ones in like Vermont. Like, it was a very long drive. So I never actually saw anyone from that list. But then I just stopped the care because everybody that I was seeing locally, it wasn't helping me. The tests weren't showing any answers. And I didn't have the means to do all of the traveling for how far away those naturopathic doctors were. But yeah, I'm still confused on that particular piece, because to now tell me your plan doesn't include naturopathic care after having given me that is a little confusing.
Yes.
So do you know if your husband's plan, because every year typically you have, because I used to be a benefits counselor, and every year you have to sign up for whatever plan. Did you guys change the plan at all?
To my knowledge, he did not. He's worked for the same company. It's been the same plan to my knowledge.
Okay, thank you.
Yeah.
Are there any other questions? Thank you very much.
Thank you.
Is there anyone else that would like to speak on Senate Bill 550 that hasn't signed up? And that, we're going to close the hearing.
Okay. Oh, he's on the ball. Excellent. Okay, you ready? Sophie?
I'm ready.
Yeah. So we're going to open up the hearing to SB 646FN and hear from the prime sponsor.
Thank you very much. For the record, my name is David Rocher, representing Senate District 1. I'm going to be brief with this. I'll try to be brief. So I think everyone here, through our roles in legislature, has been approached by the need for mental health changes. I think everyone has said we need to change the mental health system. And, you know, in digging into that a little bit, what does that mean? That could mean a lot of things. We hear a lot of things that changes the mental health system. You know, I was approached by one of my community mental health centers. It travels that, believe it or not, I think they actually have a larger area they cover than I do in my Senate district. It's massive. And one of the things that when I addressed this, I said, tell me what I can do to help. And you know, I think there's a lot of people down here in Concord willing to help, but you got to help us help you. And one of the things that they brought up with is that although they are covered as commercial providers, they're having trouble with billing. And whether that be, you know, and it initially came to me as, well, we bill for services and we don't get paid for them. And to the point where we bill for services or we provide services now we don't even bother billing for them because we know we're not going to get paid. So I know it's a complicated issue. I know there's a lot of moving parts, whether it's billing codes, services, level of services. So I spoke with the community and I said, well, we can blow the doors off of this, and that's what this bill does. However, it was never my intention to blow the doors off it in this manner, but that's not necessarily a bad thing. The intention was to get all parties to the table, to have some meaningful ongoing discussions and get the carriers to work with the providers to work through the issue. This bill would be called a blunt instrument, and that's what it is. It essentially provides parity of payment, matching what commercial payers pay to Medicaid, flat out and across the board. I think there's a better solution, and I think the better solution is being worked on in the way it should be worked on, and that's the parties that are involved coming to the table and talking about it. So I'm going to ask the committee to continue to hold this a little bit. I have spoken to members of the provider community. I've spoken to members of the payer community. We've been working on this. We've had several meetings throughout the fall. There's an active, ongoing discussion about this, and I think we're going to hear from them from both sides after I speak. But that's what we have before us, and you know, if we have to run with this, we will. But I'm hoping that we can get something a little more surgical rather than a dull butter knife that we have here in front of us. But I'm happy to answer any questions.
Seeing none, thank you, Senator.
Thank you.
Michelle?
For the commissioner as well, so.
And Commish.
You guys needed just a little of me today.
I think your jacket brought us a lot of good luck.
That's a very good point. That's a very good point. But I have one full week next week to keep that going, to build up that good luck.
Yeah. You wear it, man.
Anyway, well, good morning, everyone. DJ Betancourt. I have the pleasure of serving as commissioner of the New Hampshire Insurance Department. Michelle Heaton, right beside me, as you all know. So a couple of different things. First and foremost, I want to thank Senator Rochefort for setting conditions for the parties to come together to start figuring out on a carrier to provider basis how to work through what has been an incredibly difficult challenge. I've spoken with this committee, and many of you have spoken with me about the challenges that the CMHCs are facing. And I've met with the CMHCs on a couple of occasions and gotten a firsthand account of the challenges that they have. And I have a great deal of sympathy and understanding for them, because not only do they provide a lot of critical services for individuals in their catchment areas, but they are legally treated much the same as an emergency room at a hospital, which is to say when an individual comes in, they're mandated to treat that individual and then try to figure out later how to be reimbursed for the services that they've been given. And that makes them obviously unique, and it makes their challenge particularly acute. And what Senator Rochefort did, and we were happy to host, was to bring all the parties together. And it may seem simple, but one of the most surprising aspects of my job is how many problems you can solve if you can just get the parties around a table and getting them in a headspace to think collaboratively and working towards a goal of resolution. And I had a very good conversation out in the hall earlier this morning with one of the CMHCs who's currently having conversations with one of the major carriers and was very optimistic, gave me a positive report that the talks that they're having are progressing, that they've been very positive to this point. So obviously that is very, very encouraging. So I did want to set the tone there a little bit and really recognize Senator Rochefort for his effort. It is at least initially showing signs of bearing fruit. And now Michelle will take you through a couple of I guess, technical considerations.
Yeah, so we completely understand where you're coming from and what you're trying to achieve, but I think as written, there's going to be a lot of unintended consequences with this. Where it's been placed is in our mental health statute, and that means it'll apply to all mental health providers, not just CMHCs. Generally speaking, Medicaid reimbursement is usually lower than what commercial payers are paying. So to tie reimbursement for all of these types of services to Medicaid rates may be one of those unintended consequences where really we're lowering rates, and that could actually cause plans and carriers to not be in parity, which is a federal requirement. So there's some technical difficulties there. Also on page 2, lines 12 and 16, Medicare has been stricken and Medicaid put in its place. I don't think that's what was intended. Medicare has a rate schedule set, and for that reason, their rates are used for benchmarking across the country because those rates are the same across the country. The same is not true with Medicaid. Medicaid rates vary significantly by state, and so you wouldn't want to use Medicaid rates for purposes of benchmarking. So that's why Medicaid's there, is for really a benchmarking purpose, to give us a standard benchmark to compare rates. So we would suggest leaving it as Medicare and not changing it to Medicaid. So those are just some of the technical defects. We, again, understand what you're trying to achieve here, and we're happy to work with you on getting you language that will actually achieve what you're looking to do.
And I will just finally add this. I think what Senator Rochford spoke to during his testimony was he wanted to continue to have this legislation available, to borrow the metaphor. The meetings at this point and the positive encouragement that we've provided are the carrots. That would be the stick. And so I just want everybody to know before they get too comfortable or they take their foot off the gas pedal of these productive conversations that they're having, I know how to fix those issues. So don't get too comfortable. Keep going.
Thank you very much, Commissioner. Are there any questions? Thank you.
We're afraid to.
Roland Lammy. Saw him. I don't see him anymore.
Uh-oh. Brought up as heavy hitters.
Thank you, Mr. Chairman. If it's okay, Roland, I was gonna joke and say he had to leave to go to a PT meeting, but you heard him.
Please.
He did have a conflict and wasn't able to be here, so I'm gonna summarize his testimony. Let me start by saying that, as you all know, we were here a year ago trying to deal with this issue, and to be honest, we have made some progress. And I'm almost close to saying we're in the red zone, but we need to get across the goal line. Which I think I don't know, maybe I'm being a little too generous on that front, but we do need to get across the goal line. So I think it's important that the state be involved in this, both from the Department of Insurance and in the legislature. As you know, Senator Rochford, I work closely with you to draft a blunt instrument, and sometimes blunt instruments work. I don't want to get into today, whether the state's parity statute is preferable to the federal government's or not, because I'm not sure that we necessarily need to use it. But I don't think from the folks that we're caring for, the bill as drafted is actually quite workable for the patients and the folks that come in the door. And as Commissioner Betancourt said, there's a way to make the blunt instrument work. I agree with him on that. So let me just summarize the issues that are before us. I think the title of the bill is very appropriate because it says that we're trying to set up a standard of care for mental illness. And I think from a state interest perspective, this is my view. The carriers might not agree with me. The standard of care should be the same whether you walk into a mental health center and you're paying for it out of pocket, or you're covered by Medicaid, or you have commercial insurance. There should be some standards associated with that. And that has been, a challenge to get everybody around the table to agree. And perhaps we can find an agreement without all agreeing to that. I must say we are primarily focused on addressing this issue for the community mental health centers because they are the backbone of mental health care in New Hampshire. And the problem that we are trying to resolve is that some commercial carriers do not reimburse for medically necessary care. There's a category of services that the mental health centers provide that they are reimbursed for through the Medicaid program that care for folks in the community in a way that it improves their condition, it makes them function better, and they're able to get better. There are folks here today that can speak better to the efficacy of the case management services and the functional support services that your constituents receive at the mental health centers and why they are medically necessary. That has been a little bit of a dispute between some of the folks at the insurance department and the carriers, that they don't deem these services medically necessary, but we all know through the Medicaid program they are, and because the licensed credentialed professionals that recommend that care deem them to be medically necessary, that they are. That's among the challenges that we're all trying to confront. The reason that we drafted the bill to address, to make some modifications to the state's mental health parity law, because our view is that this isn't any sort of a new mandate, but in fact, it's about enforcing the standards of care that are medically necessary for the tens of thousands of people that present themselves to the community mental health centers. I would say, though, one of the things we learned in the process that has been underway for the last year or so is it's a relatively small number of individuals that are not receiving this care, which to a $1 billion insurance company might not be a lot of money, but to the community mental health centers, it can add up. Senator Bertzel, as you know, the Finance Committee last year in the budget had to appropriate $10 million to deal with the uncompensated care issues at the community mental health centers. Many of those uncompensated care issues are driven by inadequate commercial insurance. So there is a state interest in trying to resolve this. What I think we can do with this bill is begin to tackle what we've been describing as structural stigma. That we all know, I've been working in this space for 20 years before the New Hampshire legislature, perhaps a little more than that. We've made terrific strides. When you look at the issues around stigma, mental health stigma, when it comes to public policy in New Hampshire, it just doesn't exist the way it used to. But we do continue to struggle with it in sectors outside of the State House. And this is one of the things that I think Senator Rochford, you and others are trying to help us resolve and kind of move past that lack of complete understanding of the care that takes place at the community mental health centers. So I think we are off to a good start. We are not across the goal line yet. I don't know what the timeline is for you, Senator, but deadlines really seem to get people moving. We certainly have the sense from the commercial insurers you hear from today that we all have a better understanding of what are the issues and how we might resolve them, but they do remain unresolved. So I am happy to try to answer. Let me just say, I don't want to lean in too heavily in the fiscal note, but I'm not sure that I'm convinced, and I think the fiscal note is a little vague about this too, whether the defrailment issue really applies to this bill the way it's written, because this isn't about something new that's being provided, it's about enforcing the existing requirements. As I said, there are folks here that deal with the billing departments at the community mental health centers, as well as Chris Kozak from who's an executive director for one of the mental health centers that can speak to the efficacy of the issues that we're trying to resolve. I know you're a little crunched for time, but folks did travel here, so they're available to you to answer questions that I cannot.
Thank you very much. Are there any questions? Senator Prentice.
Thank you, Chair Rochford, and thank you, Jim, for taking my question. This may be for someone else, but I'll start with you. You described under medical necessity that there are some things that Medicaid covers that are considered medically necessary, say by Medicaid, that are not considered medically necessary or are not covered by the private plans. Do you have like a list of those, or?
I'll identify them broadly, but Chris Kozak, who signed up to speak, can speak to them more specifically.
Okay.
But it's a set of services that fall under the category of case management. Okay. One of the things we discovered is our definition of case management is different than their. So and then functional support services. So, and there's more to it than that, but he can speak to that.
Thank you.
Any other questions? Thank you very much. And we will hear from Chris Kozak next.
Excuse me. Thank you, Chairman Rochford, members of the Senate Health and Human Services Committee. As you heard, my name is Chris Kozak. I'm the president and CEO of Community Partners. We are one of the 10 mental health centers, and we cover Stratford County. I'm here today to support Senate Bill 646 due to the positive impact it would have on the individuals that we serve. In terms of medically necessary services that currently get lost in the shuffle. I just handed out a copy of my written testimony. I'm not going to read that to you or go over that. I just want to call out 1 or 2 points in there as we go through this. First, just a little bit of my background. Before I became CEO of a mental health center, I spent about 15 years in the managed behavioral healthcare space. I took one of the organizations through the licensing process, 420J, RSA 420J here in New Hampshire. I had the pleasure of going through a market conduct assessment from the Department of Insurance. So I'm well versed and aware of how the process works and what medical necessity is and how those determinations get made through an organizational level. What I see 646, Senate Bill 646 attempting to do is really level the playing field for anyone in the state with a serious mental illness. And that's an important distinction between what they call any mental illness or AMI versus serious mental illness or SMI. The individuals we see with SMI that have Medicaid coverage have full access to something called functional support services and targeted case management. Functional support services are community-based services. Targeted case management assists with what's going on therapeutically and psychiatrically with people to make sure that other factors are not interfering with their ability to progress. The two services have long been deemed not medically necessary by commercial carriers in the state. And I guess I just want to think about that for a moment. Generally, at least when I was in the field, and I don't think this changed much, medical necessity was generally thought of as healthcare services or supplies needed to diagnose or treat an illness, injury, or disease adhering to generally accepted standards of medical practice. These services must be clinically appropriate in terms of type, frequency, and duration, and not primarily for the convenience of the patient or provider. So when I look at the functional support case and targeted case management services I just spoke of, they're definitely used to treat an illness. There's a clear distinction and category by states rule in terms of what qualifies diagnostically as SMI. They adhere to generally accepted standards of medical practice. It's built into your Medicaid program. These are part of an evidence-based practice known as ACT teams, Assertive Community Treatment Teams, right? All of these services are part of that. They're evidence-based. They are standards of medical practice. Are they appropriate to the type of service we rendered? Yeah. This is a different population than somebody who simply might have depression. These are people who might have anxiety or intrusive thoughts as they go out into public that can interfere with their ability to do things. And so these community-based services to work with them while they are out in public trying to navigate and live in their natural environment are critical to their rehabilitation. And these are not for anybody's convenience. Right? It's far more convenient to have somebody come into our office and treat them as opposed to going out in the community with them. So there's no convenience factor here. Despite this, we're now, I think, in the 4th year of discussing some type of legislation to ensure everyone in New Hampshire with SMI has access to the same types of services regardless of their insurance. Similar community-based services are covered with medical conditions, often as part of rehabilitation. The same should be true for those who are in rehabilitation and recovery with SMI. And I will take questions.
Are there any questions? No, thank you very much.
Thank you.
Sabrina.
Sorry. Good morning, Senator Rochford. Is it still morning? Yes. And members of the committee. My name is Sabrina Dunlap. I'm Senior Director of Government Relations for Anthem. Thank you for the opportunity to testify on SB 646. We are opposed to this bill as drafted. As drafted, we think it's quite problematic. And we don't think it's necessary in light of our ongoing work directly with some of the CMHCs on some of the challenges raised. I do want to note, I think Jim mentioned it, that the population we're talking about that have commercial insurance that go to the CMHCs is very small. My memory from our meetings last fall that, thank you, Senator Rochford, organized, I think one of the CMHCs only had 5% of their population had commercial insurance. I think the biggest population was maybe 20 to 30%. So it's a really small population. So we want to be part of the solution. We consider the community mental health centers our partners. I just want to note that what we're talking about is like, even if we can help, it's a very small number of people, a small volume that we're talking about. So again, going back to the fall when Senator Rochford organized a stakeholder group to discuss these issues, after meeting a couple of times as a group, I then met with Roland Lammy, with one of my colleagues, who is the Vice President of Networks for New Hampshire. She and her team do all of the contracting for Anthem in New Hampshire. I think our first meeting was more than an hour. We had a really great discussion, and we were really able to hone in on what was the challenge they wanted to address. And it came down to 3 codes. And so that is what we are currently working on. These would be 3 new codes that we add to our contracts for coverage. I do just want to note that we have been talking about similar issues, not this exact issue, for years. And the insurance department did organize a group of us a year or 2 ago. We went through a list of services and codes, and we actually compared Medicaid to commercial. Oftentimes the services are covered, but they're covered under different codes between Medicaid and commercial insurance, so it can be confusing. So we actually have a full chart to try to find where the gaps in services were, and it was very small. And in fact, the insurance department issued a really helpful bulletin on this. I think that was in 2024. So I just wanted to raise that sometimes it comes down to sort of confusion around coding and billing, which is understandable. So what came out of that meeting with Roland, and these are ongoing, I just want to be clear about that, came down to these 3 codes. And I just want to note that it is simply a fact that Medicaid is different from commercial insurance. And it is sort of new to commercial insurance to do functional support services and services that historically have not been considered medical because some of them simply are not clinical in nature. That's not to diminish them, it is simply a fact. And to explain why historically health insurance might not cover these types of functional support services. I think within the 3 codes we're talking about with Roland, some of them we actually do cover. There is one in particular that is strictly functional support that I believe we do not cover. We are actively working to see if we can add these services. It is not a medical necessity issue. It comes down to these things are simply not currently covered benefits. They are just so far outside the realm of health insurance that they're not even in the mix. So it's not an issue of medical necessity. It is that currently they're just not a covered benefit, I think, for any commercial carrier. So it's more complicated than just flipping a switch. And so I just want to be clear that we are diligently working on this. I would not agree with the characterization that these are unresolved issues. I think that we are resolving the issues and we are working diligently on them. I won't get into the issues with the language because we have a lot of problems with what the language would actually do. We understand it was sort of a placeholder and appreciate that. So I would just say, in closing, we are working, Anthem has made access to mental health priority the last couple of years. We've reduced copays for kids. We've gotten rid of them entirely. This is helping. It's reducing barriers, it's increasing access, and we see that in our utilization, which is very high, which is good. It means people are getting access to the mental health care they need. And so I just want to note, we are always happy to come to the table. I would say the same for my fellow carriers. I don't think legislation is necessary to bring us to the table. So I just want to be very clear about that. And my hope is that we can continue to work in a constructive way with the CMHCs to come up with a solution. So thank you very much. I'm happy to take any questions.
Great, thank you, Sabrina. And yes, I do, you have been very proactive, and, you know, I know that the conversations are ongoing, and I appreciate that. I know the members, my constituents who have this concern appreciate that. So we hope this can be resolved. You understand we're under a timeline as well, so that probably will affect your timeline. And I know you've been updating me every time you see me in the hall. So I appreciate that very much. You've kept me very much up to speed on this, and I want to thank you for that. And I think that you have recognized the need and the concern. And, you know, I'm not going to sit here and tell you that I know everything about billing for mental health services. It's been a learning curve for me, but I think we're hopefully have a good dialogue, and we can come to some resolution. So I appreciate the work that you've done and your colleagues have done as well. So are there any questions for Sabrina? Senator Prentice.
Thank you, Chair Rochford. Sabrina, thank you for taking my question. So this, you talked about gaps in services. And does that link to my earlier question to Jim Monahan about what's covered by Medicaid that's not covered by the plans, or is that something different?
Can you just repeat what the exact question was? I'm sorry.
Okay, so earlier, Jim Monahan described that there were services that were covered by Medicaid that are not covered by the health plans that are considered medically necessary. And in broad terms, it was case management and functional care, because case management would probably be the best description of things that are have the same title but are different. So you had called up a document and said there's some gaps in access. Is that what you're talking about?
Thank you. So yeah, so this, and I'm happy to circulate this. I think it's a really helpful document. I am talking about that. I think it comes down to this quite a narrow group of functional support services. Sometimes I think in other contexts are referred to as wraparound. These are things to help people with daily living, which historically, again, they have not been considered clinical. That's not just us. That's just the nature of these services. So that would be a place where, you know, Medicaid does cover those services, but historically we have not. And in this case, these are the three specific codes that cover things. They're things like helping people fill out forms and things that are not necessarily clinical. So that is sort of the gap. And I think it's a pretty narrow gap, and it has closed over the years. So, you know, if you put Medicaid up against commercial insurance, certainly in the mental health realm, it's a minimal gap, I would say. And that's not to diminish it. It's just to say that, like, I think we're getting there, and we recognize the importance of these services, which is why my team is working right now to try to add them.
It'd be great to have that list.
Okay.
Thank you.
Thank
You don't have to give me your copy, but
Okay.
thank you.
Any other questions for Sabrina? Oh, thank you very much.
Thank you.
Paula Rogers.
Thank you, Mr. Chairman. Again, members of the committee, thank you for the opportunity to comment on this bill. I'm going to provide just a handout. Don't look at it now, it's too lengthy. But it really is something that I think is the pivot to the conversation we're having here, and also to Senator Birdsell's bill from last session, which was the bill, I think it was Senate Bill 128, regarding the Fast Forward program, because we're dealing with the same unfortunate rub. It's unfortunate because people here, as proponents of a change, are feeling that somehow they are not getting paid for services they're providing to their clients, whether it's clients in the mental health centers or clients in the Fast Forward program. And so the issue developed, and the insurance department, the item I'm handing out to you, basically took a look at all the procedure codes that might be utilized and provided a bulletin. And within the bulletin, I've put a star, I think it's on the second page, because it gets to the issue of certain services provided in either the Fast Forward program or at the community mental health centers are services which traditionally commercial carriers have not covered. And so if you look and read the whole bulletin and looked at all the codes, you'd come down to several that are simply at issue, and there may be more. I'm not in the middle of any discussions with mental health centers or indeed with the care management folks at the Fast Forward program, but there are discussions going on. And the question becomes, how can we get to a point where we develop an understanding and an opportunity perhaps to address those particular codes? There's no guarantee we can get there, but there are ways perhaps of looking at some sort of bundled payment, exploring opportunities to see if there's something that can be done. Obviously, the legislation before you, and Senator Rochefort, you've discussed this as well, it is basically a placeholder with the hope that there'll be some exerted pressure and additional pressure to get the insurance department, maybe the folks, when we get to, I guess Senator Birdsell's bill is in again this session, maybe the folks at HHS and the care management programs and the CMHCs, each to address their own issues, because they do rub up against the same issue at heart, which is there is a difference between the public programs that Medicaid provides and what commercial insurers have provided or are required to provide. And it gets down to, is it medically necessary? Is it clinically necessary? Are the people delivering the service in such a setting that they're supervised, for example, by a credentialed person? How does that all work? And those are questions that come out in a contracting discussion. And they're difficult to discuss in some meaningful way before a legislative committee of policymakers who are trying to solve a problem. You've heard a lot about it. There's a lot of pressure behind it, and I'm certainly encouraging further discussion amongst the people that have the capacity to see what they can do about it. And in fact, if they can't do the entire task that's presented to them, to come forward and say, this is where we are, we've made progress, we can't get there, it will have to play its way out.
Great, thank you. Are there any questions for Paul? Thank you very much. Peter Bragdon. All right, thank you. We appreciate that. Holly Stevens.
Hi, Chairman and members of the committee. My name is Holly Stevens. I'm the Director of Public Policy at NAMI, New Hampshire, the National Alliance on Mental Illness. We're a grassroots organization whose mission is to improve the lives of all individuals impacted by mental illness and suicide through support, advocacy, and education. Last year, we served over about 55,000 individuals around the Granite State. These are individuals that are impacted by the issue that we're talking about right now. And in the discussion that we've had so far, I've heard about payers and I've heard about insurers. What I haven't heard is the patients. And those are the folks that we represent. And I do want to ask that as conversations continue, if there's any way that we can be involved in them, we would really appreciate that. There are individuals that end up being hospitalized in New Hampshire Hospital on an involuntary basis. They are then conditionally discharged to the community mental health centers, and they are ordered to be served by certain services. They must participate in those services. Some of those are the services we're talking about today. If those individuals have commercial insurance, it's not being paid for, which means they either have to pay for it out of their own pocket or risk going back to New Hampshire Hospital because they're not complying with the treatment. So there may be only a handful of individuals that are affected by this legislation, but they're seriously impacted by it. Either they're re-hospitalized or they have to pay thousands of dollars for these services that they may not have. I did want to talk about a specific story of somebody that I met when I did This Is My Brave 2 years ago. We were in the cast together. They had been a patient of Riverbend since early adolescence. And when they started to launch into adulthood, they obtained full-time employment at a local nursing home in the kitchen and became commercially insured. At that point in time, this person was told, you either need to start paying for certain services at Riverbend or give up those services. And they were the case management and the functional support services that we've talked about. So as this person was starting to launch into adulthood, in a time when it was critical to have these services in place, they lost them. They currently have a $9,000 outstanding bill with Riverbend that they're not able to pay. They don't think they'll ever be able to pay it. And even though, yes, that's uncompensated care for Riverbend, this is a debt that's being held over somebody's head. And that's one of the constituents of this state. If the commercial insurance had paid for these services, they wouldn't have. She also did her mental health decompensated during this time. And luckily, she's now connected with a therapist, and only a therapist, who serves her. She doesn't have the functional support services because the insurance won't pay for them. But she's doing well, despite that, with just the services of the therapist. If her commercial insurance had covered these services, she wouldn't have decompensated, and she wouldn't be with this, $9,000 bill over her head. So for those reasons, we do support this bill, even as it's drafted, because the insurers, it's been a lot to try to get the insurers to come to the table and recognize these services as being services that are akin to rehabilitative services for somebody who may have a surgery, who's in the community, who's receiving med management, who's receiving in-home nursing services, that they're also paying for. These are akin to those services. And so we do see this as a parity issue, that these services are not being covered by commercial insurers. And again, we would like to be at the table if conversations are ongoing. And with that, I will take any questions.
Thank you very much. Are there any questions? Thank you very much.
Thank you.
Is there anyone else that would like to speak on Senate Bill 646? Cam? All right. With that, I'm going to close the hearing. Motion to adjourn.
Seconded.
All those in favor say aye.
Aye.